it is very much important to get a desired rexis. If a desired rexis is achieved, then we can manipulate the nucleus and can prevent most of the complication during the management of the nucleus. So, coming to the rexis, what are the conditions which post uphill task during the rexis? Most of the commonest will be intumescent hypermature cataracts, like pediatric cataract and cataracts with in glaucoma, actually angle closure glaucoma. I will restrict myself to the hypermature intumescent cataract. Before understanding, before going to the cases, let us understand what are the differences or what is the changes that is taking place in a hypermature cataract compared to the grade NS2 or 2 to 3. There will be increase in the intralenticular pressure in the hypermature cataract, and entry capsule will be more stretched, especially in the center. Entry chamber will be shallow to normal. Vitreous will exert more pressure on the lens due to the fluidic cortex, and the nucleus will be either mobile or stable. So this is a picture of Argentinian sign, though it looks very nice, but none of the surgeons want it to be in their operating room. So to avoid this type of situation, better to get adjusted to the this type of cataract with a simple modification. Then what are the modifications we can go? To reduce the intravitreal pressure, pre-op mannitol, stain the entry capsule with a trypan blue at least for 1 minute. To reduce the lenticular pressure, use a single and adequate OVD. Primary rexis to be started in the center to about 2 to 3 mm, where the capsule is the thickest. Aspirate the loose cortical matter to create the space and decompress the lenticular pressure. And the instruments which are must in the OT table are microrexis forceps and microrexis scissors. For all clinical purpose, we divide the hypermature cataract into two types. One is a fluid-filled hypermature cataract, and another one is a non-fluid-filled hypermature cataract. In a fluid-filled hypermature cataract, we can see areas of island of fluid which are separated by a dense or hydrated capsule, hydrated cortex. So these cataracts behave differently compared to the non-fluid hypermature cataract. Once we make a nick in this fluid-filled hypermature cataract, usually fluid is released and it enters into the AC and it decompresses the capsule. But it doesn't happen in the non-fluid filled hypermature cataract, where the whole cortex will be swollen and hydrated, and it will be exerting more pressure on the entry capsule, which is more dangerous, and we have to identify pre-operatively and should manage it properly. Then I will go to the video. I am presenting two cases. One is a fluid-filled intumescent cataract. The capsule is stained well, at least for 1 minute. Then HPMC OVD is being used. Fill the AC properly and completely. A nick is being made. Then with the help of microrexis forceps, I am trying to create a rexis of 2 to 3 mm. We can use the tearing or shearing forces and adjust your position according to the position of the capsule. Even we can use the cystotome to complete the rexis. And try to use OVD as much as possible to flatten the capsule. Then decompress the lens by using a bimanual IA. Remove the cortical, loose cortical matter and as well as the fluid. Try to do it in all the direction and all the angles. 360 degrees should be covered, so that lens will be decompressed completely. Then give a tangential nick to the primary rexis. With the help of micro laser, start the secondary adequate or desired rexis. And here it completes the rexis. So it's a double rexis technique. So next case I am presenting here is a non-fluid intumescent cataract. Just I want to show what are the difference and how a small rexis can create a problem. Here I have made a very small rexis with and I try to remove the cortex, but the cortex is just like a sheet. I am not able to remove. Suddenly, in the middle of the surgery, I try to go inside the lens. Suddenly, this happens, and there is a vertical cut in the primary rexis. Here I can't do a second rexis because still I have not decompressed the lens completely. So I decided to go to manage first this cut. So I enlarge this cut and to make it to another rexis. And made a flap and want to continue in the same range, so that I can achieve a rexis of around 3 to 4 mm. Then I did a decompression of the lens by removing the loose cortex. (360°). Then a tangential. The remaining part is as same as the previous case.
So that became a triple rexis.
Yes, sir. To conclude, take-home message: preoperative mannitol is must. Stain the entry capsule adequately with the trypan glue at least for 1 minute, and adequate single viscoelastic should be used. Then the primary rexis should be about 2 to 3 mm, and decompress the lens before attempting for a secondary rexis. Thank you.
Wonderful talk, Dr. Sharan. Very nice videos in spite of the hitches. So thank you very much. So next we have Dr. Sheetal Ballal, who will be telling us how to make our patients happy with accurate biometry. I think decompressing is the key. So any tips, sir? TKRMS, sir, for rexis and hypermature cataract? Will not work.
Filling the anterior chamber with visco also, you have to be very careful. Yeah, it should neither become shallow or
tight.
You should not overfill.
Overfill it. That's true.
higher viscoelastic, higher density viscoelastic also helps, not something that flows out very rapidly. And probably if you are doing with a forceps, it becomes more challenging. If you are doing with a needle, because your chamber is closed, it's much easier.
Respected seniors and dear friends, good afternoon. My talk is on accurate biometry. As we know, biometry by definition is a practice of applying mathematics to biology. However, in ophthalmology, the term biometry is typically used for a preoperative measurement for our IR power calculations. So why do we need it to be so accurate? So as we know, cataract surgeries are now more of refractive procedures and patients' expectations are very high. Most of the surgeons achieve about 76 to 80% of patients within the plus minus 0.5 diopters of targeted refraction. And with better techniques and precision biometry, it is possible to achieve more than 95% of patients in this range. So what are the factors we use for calculation of the IL power? Traditionally, it was just two factors, the axial length and keratometry. However, with the advent of newer formulae, we have various other measurements which come into play, like the corneal thickness, ACD, lens thickness, and the corneal diameter. The axial length is the most important parameter which is used in the modern day formulae, and any change in the power in the axial length measurement, like a 1 mm error, can lead to approximately a 2.5 diopter post-op error. So the axial length can be measured using two techniques, as we know. One is the ultrasound and second are the optical biometers. So the ultrasound biometers are very popular, cost-effective instruments, still very commonly used in most practices. So here there are two methods of acquiring the scan. One is the contact and the immersion. The contact involves placing the probe directly on the cornea. However, a misaligned probe or inadvertent compression of the cornea is the biggest drawback, because this alters the axial length measurement. And also, if it is not sanitized adequately, it can lead to infection of the patient. So to overcome these, we have the second technique, which is the immersion biometry. So this involves placing a scleral shell with saline, and the probe is placed in the saline. So this is more reliable because the risk of corneal compression is eliminated, and also the risk of infection is negligible. However, it is still a challenge to make sure that the alignment is accurate in these cases, and also cumbersome for the patient. So what are the, how do we get the scans? Basically, it uses a ultrasound wave of 10 megahertz, and part of this ultrasound reflects from each interface in the eye, and this is shown as spikes on the scan. So greater the difference between the media, the stronger the spike. So in contact method, we get 5 high amplitude spikes and a steeply rising retinal spike. And in the immersion, there is an extra 6 spike for the probe. Another word on gain. So there is a parameter called gain, which affects the amplification and resolution of the displayed spikes. So if the gain is too high, the resolution reduces. So basically, structures which are close together are seen as a single spike, like the retina and sclera. So when you see this flat top spike of the retina, it means that the gain is too high and it needs to be reduced. So tips for accurate measurement using an ultrasound biometer are: first of all, ensure that the machine is calibrated properly. Echoes from the cornea, anterior posterior lens, retina should be of good amplitude, and if there is any misalignment, this should be looked for. Avoid corneal compression, and ideally take at least 5 to 10 good consistent readings with the lowest standard deviation of less than 0.06. A word of caution: special care to be taken in eyes which are unusual, that is either too short or too long, because the chances of error in these patients are higher, and the difference between the two eyes should be less than 0.3. Look out for corneal compression. And how do you make this out? So any of your readings where the ACD is very shallow should not be used, even if the spikes look good. And misalignment should be looked for. That is, if the retinal spike is not rising sharply, or you see a single spike where the scleral spike is absent, and this would mean that it has gone through the optic nerve, and hence there is misalignment of the probe. Also, in high myopes, the posterior staphyloma are challenging because these can lead to faulty readings of the axial length. The main drawbacks of the ultrasound, apart from what I've already mentioned about the corneal compression is that it requires a skilled technician to take proper readings, and also the ultrasound measures the axial length up to the internal limiting membrane and by adds 200 microns for the retina, though the average retinal thickness could be vary between 160 and 400. So there is a little bit of a discrepancy there, and also this machine does not measure the keratometry readings, and we need a separate instrument for this. So to overcome these, the optical biometers were introduced, which were a game changer. These are non-contact automated machines which have very accurate readings. There is no corneal compression and increased overall accuracy. So in the optical biometers, the accuracy is seen to be within 0.01 millimeter versus A scan, which is 0.12. And here the patient fixes on a light. So invariably, the scans are through the fovea, or we measure the optical axial length. The first optical biometer to be introduced was the IOLMaster 500, which was introduced in 1999 based on the partial coherence interferometry principle using the 780 nanometer infrared laser. These were extremely useful in most patients, but it was found that in the presence of a dense opacity or in very dense cataracts, the measurements were not possible. After this, there were various other optical biometers which were introduced over the years with improvements, and currently the gold standard is the swept source OCT based machines, which give the most accurate readings, and the popular one is the IOLMaster 700 by Carl Zeiss. So in this machine, it uses a full spectrum superluminescent diode laser which sweeps back and forth, and these are faster and more accurate and versatile than the traditional OCT. Here, this machine takes about 2000 scans per second and divides the eye into 6 quadrants. So here, this machine provides a full-length OCT image of the eye. At a glance, you can see right from the cornea up to the retina, and the maximum depth of the scan is 44 millimeters. So there are fewer refractive surprises because by seeing the foveal pit in these scans, you can make sure that the fixation of the patient was good. The other technology in this IOLMaster 700 is the 3-zone telecentric keratometry. So this is distance independent keratometry. So what it means is that even if the patient is a bit uncooperative and moving, the distance between 2 spots on the cornea remain constant, and hence the accuracy is much better. Also, by visually assessing these dots, you can also make out the integrity of the tear film. The other patented technology is the total keratometry reading in this machine. So recently we have a lot of stress on the actual measurement of the posterior cornea. So in this machine, it replaces assumptions and actually measures the posterior cornea with this value called the total keratometry. So it measures, it uses the telecentric keratometry as well as swept source OCT to measure the anterior cornea, the thickness of the cornea, and corresponding points on the posterior cornea called the posterior torus fit. So a combination of these three are used to measure the total cornea, and this TK reading is used in most of the IOL formulae for very accurate measurements. Now, the other advantage of this machine is that it gives you a measurement of the quality check. So while measuring, you get a green tick if the signal quality is good, and it is easier to identify these scans. Apart from that, it also captures the blood vessels near the limbus, and these can be used for the markerless toric workflow, like if the doctor is using the Zeiss Callisto system. The IOLMaster is also incorporated with various the latest generation of IOL formulae like the Barrett suit and the Haigis, which are extremely accurate, especially in the unusual eyes. Now, what are the things you look for in the scan in the IOLMaster? First and foremost, like I've mentioned, look for the fixation check. So once you see the foveal pit, you know that the fixation is proper, as compared to this patient where the foveal pit is not visible and the fixation is poor, and hence these readings should not be taken. Apart from that, in consecutive measurements, the difference in the axial length should be less than 30 microns. For example, in this patient, we see that though the measurements look fine, the difference in axial length is more than 30 microns, and that is because of a slight tilt in the second reading, and hence not an accurate reading. The difference in the in the K readings also should be considered, and the difference should be less than 0.5 diopters. If it is more than 0.5 diopters, the readings are incorrect. The other features which the IL master shows is any abnormal geometry like a lens tilt or a subluxation, which can be seen in the scans. And it also gives a hint of any macular pathology, for example, a macular hole or edema, which is visible in the scan, though not diagnostic, but it can be used for further checking that in detail. Apart from the various advantages I have mentioned, it does have a few disadvantages, the main thing being the cost factor. Also, these are not advantages in 100% of the patients. With the recent advances, it is useful in about 90% or 95%, but still there are a few cataracts which still need the ultrasound for measurement. Coming to the next, which is the keratometry, which is the second most important factor, and any deviation causes a change in IL power in a ratio of 1:1. The ultrasound requires a separate measurement in the form of a manual keratometer or an auto-K, or even the sham plug based machines like the Pentacam. However, the optical biometers, as I have mentioned, have a very robust method of measuring the keratometry. The other factors like the anterior chamber depth, lens thickness, and corneal diameter are very important, though they may not alter it as much as the axial length and keratometer. However, these measurements are important and are incorporated in all the recent formulae. Finally, once the measurements are very accurately done, the final step is to choose the right formulae for your calculation. So the historical and regression based formulae are no longer used. It is the Virgin's formulae which are used in most of the machines. And among this, the recent formulae like the 5 variable formulae of the Barrett Universal 2 is the gold standard and seen to be most accurate. Recent technology like ray tracing, which is used in the Olsen, and artificial intelligence used in Hill, RBF, and Kane are also found to be extremely useful in most patients. So this just summarizes the IL formulae, and what this shows is that the central column is the for the normal eye. So for a normal eye, most of the formulae work well right from the SRKT, Haig's, Holiday 2. But when it is the unusual eyes, that is either the very short or very long eyes, that's when the errors come in, and there the older formulae do tend to have errors. And in these cases, it is better to rely on the recent formulae. For example, in long eyes, it is found that the Barrett, Olsen, Haig's, Holiday are definitely more reliable than the older formulae, whereas in short eyes, where the room for error is much bigger, it is the Barrett, Hill, RBF, and Kane which do much better. So to conclude, the recent development in biometers combined with improved formulae have allowed for precise refractive measurement after cataract surgery. And each biometer has its strengths and weaknesses and should carefully consider the intended patient population and technician skill levels and cost while deciding which one to purchase. While optical biometry has become the mainstay in modern ophthalmic practice, the ultrasound also have their role and cannot be discarded. And in the end, it is very important to also choose the right formulae for every patient.
Thank you very much, madam, for the wonderful talk. So, meanwhile, we have Dr. Ravi Krishna, who will be talking to us about phaco chopping techniques and parameters. To just give an introduction, he is one of a prolific cataract surgeons at Nethrakalpa. Does about 50 to 75 surgeries in a day. So we'll have a lot to learn from him. And meanwhile, any questions for Dr. Sheetal? Yes, sir.
Ma'am, in the case of high myopia and cases of, say, staphyloma and such eyes, optical biometry and ultrasound readings would be quite different. And which would we be relying on?
It is in these unusual eyes where I think the optical biometers definitely do much better. And here you can see the entire length of the scan, and you can definitely make out where the scan is going. And also because the patient fixates on a light, you know that it is going through the optical axis compared to the ultrasound, where you're checking the fixation becomes an issue, and the errors due to posterior cephaloma are much higher.
Most importantly, I was just discussing the same with Dr. Jyoti Shetty madam also. It's very important that we see the scans individually because most of the time the technician does it and we just blindly rely on that. So it's very, very important that we see the scan, it has been taken properly, especially with the ultrasound scan, whether the spikes are proper, so that we can have an accurate biometry.
I always say the woman or the man behind the machine is more important, So you look at the scans yourself. I think none of us are that busy that at the end of the day, we can't select our own scans and calculate our own intraocular lens power. I think we owe it to the patient.
The optical biometers require less skill in acquisition compared to an ultrasound. So if it is an ultrasound machine, ideally should be done either by a very trained technician or the doctor himself.
Thank you. I think Dr. Ravi is ready with the talk and we just pray the video works.
So good afternoon, everyone. I would like to thank Tumkur Ophthalmic Society for having me here. So I'll be talking about phaco chopping technique and parameters. So as you all know that the chopping technique has these many, there are many chopping technique like divide and conquer technique, stop and chop, vertical chop which has horizontal and vertical component, and mechanical chop, and you can chop using a laser, that is flax, and terminal chop, and using a my loop also we can do a chopping. So the first thing which is taught in the training is divide and conquer technique. So here there are grooves made, the first groove and the second groove. So basically this has a easier learning curve, and the trenching to a good depth is a key in this technique, and the higher phaco energy is utilized. So the first training starts with this technique. So, and second thing is engaging the nucleus in the trench at correct depth leads to a splitting forces. If you do it more superficially, then it will just cause a cheese wiring. So it's better to go into the depth and try to separate, then it separates. I'll not go into the detail of. I'll just show one video. So I personally have learned direct chop. I have not started learning doing divide and conquer. So one of my colleague has helped me with this video. So initial trenching is done with the low parameters. So this is the initial groove, and you should make sure that you don't go too deep. Otherwise, you'll end up trenching the PC also. So then you rotate the nucleus 180 degree, then do the trench perpendicular to the initial trench. So after doing this, once you achieve the correct depth, just go into the groove and try to split into 4 pieces and emulsify. So these are the parameters which are used for initial sculpting. So keep the parameters on the lower side. Don't use too much of energy. Don't use too much of vacuum. So like this is a Centurion machine setting which my colleagues use for trenching. Then coming to the chop and stop. So after the initial trench divide and conquer technique, this is the technique which is taught during fellowship. So here it bypasses the difficulty of making initial chop. It's a good transitioning between the divide and conquer and direct chop, and it reduces the effective phaco energy which is utilized in the divide and conquer method. So here I'll be playing one video. So here also just do a small trench. the first trench. So that should be also a adequate depth. Then once you do that, then just try to separate. So the same thing you can do it on the other side also, rotating the nucleus to 90 degree and just try to separate. So ultimately you'll be making 4 pieces and ultimately you'll be emulsifying the same. So the role of visualizing this lens fiber is very, very important. So whenever you do trench, and after finishing the trench, you just try to see the orientation of fibers. If it is perpendicular to your probe, then it's very difficult for you to separate. If it is parallel to your probe, then it is difficult. It's easy for you to do a separation. So here it was perpendicular to the probe. That's why the surgeon had a difficulty in separating the pieces. So here it is parallel to your probe. That's why it is easy for you to separate. So you try to visualize the fiber orientation when you are trying to chop. So these are the settings which can be used for the initial sculpting, then followed by little higher parameters for chopping. So the direct chop, which is the way forward, it is faster and efficient when you have a high volume surgeries. Then better to practice this so that your surgical time comes down. So it uses less amount of energy with less stress on the zonules. So this is my own surgical video in which I have demonstrated how to do a direct vertical chop. So here I use a dialer. I never use chopper. So it's a long dialer which is around 0.5 millimeter to 0.75. So it's very easy to chop without having a fear of touching the PC. Like whenever you use a short tip chopper, then you might touch the PC sometimes and you might have a PCR. So in this, that reduces. So just go to the center, bury, then separate. So the vacuum, whatever I am using, is on the higher side. They should not be used by a like junior surgeon. So they can always keep it in linear mode. But these are all panel mode, whatever I have kept. So linear mode, you can have maybe around 150 to 400 vacuum with proportionate AFR as well as your bottle height. So once you divide into multiple pieces, like maybe 4 to 6 pieces you can have, depending on the density of calci. Just start emulsifying, keep bringing it to the center, the safe zone. So these are all settings which use for my like direct vertical chop. So I usually prefer to use a burst mode rather than continuous or pulse mode. Then that's what I was just showing, like the beginner surgeon can have those parameters and advanced experienced surgeon can have these settings. So for quadrant removal, I use like almost same, except I keep IP on, so that the intelligent phaco, so that whenever the piece gets clogged in the tip, because of the conventional phaco which is coming into picture, it just re-engages the piece and it emulsifies. So you can keep an IP on whenever you are doing a cotton removal. So this I use for my hard cataracts usually. So this is one of the best technique which can be used for harder cataract. So this is called flower petal technique, in which you just chop the mid periphery, don't chop the center part. Just try to chop all over all the quadrant. Then you will have a central hard nucleus that can be emulsified. Then it will be easy for you to emulsify the peripheral pieces. Here also the vacuum, everything is on the higher side. So this is using a Centurion machine. So this is the central hard part which I am trying to emulsify. Once that is done, then it will be very easy. Like especially you can use this for harder cataract. You can learn this technique when you are doing a NS2 cases, and slowly you can start doing it for harder cataract. So flags, we can choose how many quadrants we want, and anyhow it will not separate the posterior plate. So almost around 800 microns of thickness we have to leave. So it is like ultimately the energy delivered will be reduced when you use these flags, especially for harder cataracts. So this is one technique which was described. It's called tunnel chop. And there is one video of my loop, which is done by Dr. Naren Shetty. So the ingel rexis is like as usual. Then the loop is introduced. You have to fill the chamber with good viscoelastic. Then the loop is introduced from the main port and should be on the sides. Slowly guide the wire in between the rexis and the nucleus. Then it expands the inner edge, and you have to just withdraw so that the nucleus get cuts into pieces, two pieces. The same technique can be followed for the other side. So here also, because it's a harder cataract, the energy utilized during phacoemulsification will be less. Thank you.
Thank you, Ravi, for finishing your presentation in spite of those challenges. So he had a tough time managing his slides rather than managing the nucleus bits. Any questions for any of the speakers from the audience? Quick. I think we saved half an hour of your time. I think so. I'm not sure. But if the slides were running fast, we would have been faster. So I think with this, we'll take a break because we're really running short of time. I thank my co-moderators. We'll go on to lunch, I think.
That was a very informative session. I would like to call upon Dr. Vishwanath sir from TOS to honor our speakers, Dr. Harish Kumar and Dr. T.K. Ramesh sir. Sir, ಈ session ಗೆ ನಿಮಗೆ please come over, sir. We have some goodies for you, sir. Sir, these are books. Sir, please come over. Thank you, Dr. Harish. Vishwanath sir, Bunny sir. Here you go. He's got a saintly patience. And I would like to call Lavanya to honor Dr. Ravi Krishna and Sheetal Balan ma'am. Yeah. And Dr. Manjunath. Dr. Sharanabas. Dr. Sharan. Dr. Sharan. Yeah. Please. Sir, Dr. MSR sir, please come. ಇಲ್ಲ ಸರ್ ಇನ್ನು ಆಗ್ತಾನೆ ಇರುತ್ತೆ ಬನ್ನಿ ಸರ್. We don't want to leave you so. Yeah. Dr. Ravi Kumar. And thank you, moderators. Let's take a break and lunch break is only for 10 to 14 minutes plus 1 minute. Afternoon sessions are quite interesting, and we'll have lunch and come back here. Thank you.
ಮೇಲ್ ಮಾಡಿಲ್ಲ, ಈಗ ಬೆಳಿಗ್ಗೆ ಇವ್ರು ಕೊಟ್ಟಿದ್ರು ಪೆಂಡ್ರೈವ್. ಏನ್ ಹೆಸರು ಅವ್ರದ್ದು ಹೇಳೋ? ಅಲ್ಲಿಯೇ ಇದ್ದಾಳೆ. ಅದೇ ಅದೆಲ್ಲ ಅಲ್ಲಿ ತೋರಿಸ್ಬೇಡ, ಇಲ್ಲಿ ನೋಡಿ.
खुद का स्टार्टअप बना अच्छा है, मगर एक कड़क एमबी डिग्री के बिना थोड़ा कच्चा है।
ಹೀಗೆ ಕೇಳದೆ ನಿಮಗೀಗ ದೂರದಲ್ಲಿ ಯಾರೋ ಈ ವಂಚನಕ್ಕೂ ಆ ವಂಚನಕ್ಕೂ ಹಿಂದಿನಿಂದಲೂ ದ್ವೇಷ, ಪ್ರಭುಗೆ ಕೊಲ್ಲುವಷ್ಟು ಆಕ್ರೋಶ. ಹೀಗಿದ್ರು ಆ ಪ್ರೇಮಿಗಳು ಮಾತ್ರ ಹೆದರಲಿಲ್ಲ. ಚೆಲುವೆಯ ಮಾವಯ್ಯ ಒಲವಿನ ಕಥೆ ಕೇಳಿ ಹುಲಿಯರಂತೆ ಎಕರಾಡಿ ಸೇತುವೆ ಬಳಿ ಬಂದಾಗ ಪ್ರೇಮಿಗಳನ್ನು ಕಂಡಾಗ ರೋಷದಲ್ಲಿ ಕೂಗಾಡಿ ಎಲ್ಲರನ್ನು ಬಸಿದ ಸೇತುವೆಯ ಕಡಿದ. ಆ ಜೋಡಿಯ ಕಥೆಯೊಂದಿಗೆ ಕೊನೆಯಾಯಿತು ಹೀಗೆ. ಕೇಳದೆ ನಿಮಗೀಗ ದೂರದಲ್ಲಿ ಯಾರೋ ಹಾಡು ಹೇಳಿದಂತೆ ಒಂದು ಹೆಣ್ಣಿನ ಬಾ ಮಗ, ನೀನು ಬಾ.
ಚಿಕ್ಕಪ್ಪ ಬಹಳ ಸ್ಟ್ರಾಂಗ್ ಇದ್ದಾರೆ, ತುಂಬಾ ಸ್ಟ್ರಾಂಗ್. ಆಗ್ಲಿ
ಬಾಳೆಂದರೆ ಗೆಳೆಯ ಅನುಭವ, ಕವಿತೆ ಆತ್ಮಾನುಸಂಧಾನ. ನೆನಪೆಂದರೆ ಮಳೆಬೀಳುವ ಛಾಯೆ, ನನ್ನಿದೆಯ ಬಾಂಧಳದಿಯೋ, ನನ್ನಿದೆಯ ಬಾಂಧಳದಿ ಚಿತ್ತಾರ ಬರೆದವಳೆ, ಸುತ್ತಿರ ಲೋಕದಲ್ಲಿ ಈ ಮದ್ದೆಲ್ಲ ಸಿಗದವಳೆ, ನನ್ನೊಳಗೆ ಹಾಗಾಗಿ ಉಳಿದವಳೆ. ಸಂಪಿಗೆ ಸವಿಬಾಳಗಿ ನೀರ ಜೀವನದಿ ಬಾವಳಿಗೆ ಮಮಕಾರ ಮಾರೆ, ಲೋಕದ ಸುಖವೆಲ್ಲ ಲೋಕದ ಸುಖವೆಲ್ಲ ನಿನಗಾಗಿ ಹುಡುಕಿದರೆ ಇರುವಂತ ನನ್ನ ಕೈಯಲ್ಲಿ ಇರಲಿರಲಿ ನನಗಾಗಿ ಕಾಯುವೆನು ಕೊನೆವರೆಗೂ ಕಣ್ಣಾಗಿ. ಜನ್ಮಕ್ಕೂ 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 ಒಲಿದೊಲಿದು ಪ್ರಾಣ ನೀನೆಂದು ಜನ್ಮಕ್ಕೂ.
Tata AIG Car Insurance. Trusted name. Fantastic.
I feel like something's coming. In 2024, your life and your business won't be the same anymore. A new technology that's
ಯಾವ ಹೂವು ಯಾರ ಮುಡಿಗು ಯಾರ ಮೂಲವು ಯಾರ ಕಡೆಗೂ ಇಂಥ ಪ್ರೇಮದಾಗದೆ ಯಾರ ಹೃದಯ ಯಾರಿಗೋ ಯಾವ ಹೂವು ಯಾರ ಮುಡಿಗು ಯಾರ ಮೂಲವು ಯಾರ ಕಡೆಗೂ ಒಂದು ಸುಮವು ಹರಳಿತು ನನ್ನು ಹೊಲಿಸಿತು ಒಂದು ಸುಮವು ಹರಳಿತು ನನ್ನು ಹೊಲಿಸಿತು ಪಾಶ ಎಸೆಯಿತು ಒಂದು ಪಾದ ಕಲಿಸಿತು ಪಾಠ ಕಲಿಸಲು ಗುರು ಯಾರು ಯಾರಿಗೋ ಯಾವ ಹೂವು ಯಾರ ಮುಡಿಗು ಯಾರ ಯಾರ ಇಂಥ ಪ್ರೇಮದಾಗದೆ ಯಾರ ಹೃದಯ ಯಾರಿಗೋ ಯಾವ ಹೂವು ಯಾರ ಮುಡಿಗು ಯಾರ ಯಾರಿಗೋ ಇವತ್ತು ಯಾಕೋ ತುಂಬಾ ನೆನಪಾಗ್ತಿದ್ಯಾ. ಮಿಸ್ ಯು. ಬಾಯ್. ಸಂಜೆಯಾಗಿದೆ ಸಂಜೆಯಾಗಿದೆ ಸಂತೆ ಸಾಕಾಗಿದೆ ಸಂತೆ ಸಾಕಾಗಿದೆ ಸಂಜೆಯ ಕಾಗಿದೆ ಸಂಜೆಯ ಕಾಗಿದೆ ಸಂಜೆ ಸಾಕಾಗಿದೆ ಸಂಜೆ ಸಾಕಾಗಿದೆ ಏಕಾಂತವೇ ಅನಾಹುತವು ಏಕಾಂಗಿಯ ಸಂಲಾಪವು ಬಿಸಿಯಾಗಿದೆ ಬಿಸಿಯಾಗಿದೆ.
कल से तुम्हारी तबीयत ठीक नहीं है, जाकर डॉक्टर को दिखा क्यों नहीं आते?
ये
ಉಸಿರು ನಾರಿ ಹಾಗೆ ಮತ್ತೆ ಉಸಿರು ನೀಡುತ್ತಾ ನನ್ನನು ವಿಶೇಷವಾದ ಮೆರವಣಿಗೆ ಸಾಗವಾದ ಮೆರವಣಿಗೆ ಬಿಟ್ಟು ಎಂದು ಕೂಡ
देश के लिए कुछ करना चाहूँ सर। हमारी भारत माता है ना जो सुबह साहब, ये अपने बच्चों की हर ख्वाहिश पूरी करती है। डिफेंस मिनिस्टर दिल्ली आ रहा है।
ಮನೆಗೆ ಬಣ್ಣ ಹಚ್ಚೋ ಕಣ್ಣಿನವಳು, ಕಣ್ಣಿಗೆ ಬಟ್ಟೆ ಕಟ್ಟಿ ಪ್ರೀತಿಸಿದಳು, ಪ್ರೀತಿಗೆ ಬಣ್ಣಳು, ಹಚ್ಚು ಮುಂಚೆ ಸ್ವರ್ಗಗಳು, ಭೂಮಿಗೆ ಬೇಲಿ ಹಾಕೋ ನಗೆಯವಳು, ಬಾಯಿಗೆ ಬೀಗ ಹಾಕಿ ಪ್ರೀತಿಸಿದಳು, ಪ್ರೀತಿಸಿದ ಕ್ಷಣವೇ ಅವಳೆ ನನ್ನುಸಿರು, ಉಸಿರನೇ ಜೀವಿಸು, ಉಸಿರನೇ ಸೇವಿಸು, ಉಸಿರೇ ಉಸಿರೇ ಈ ಉಸಿರ ಕೊಡಬೇಡ, ಪ್ರೀತಿ ಹೆಸರಲಿ ಕಾಯುತ್ತಿದೆ ಮನಸ್ಸು, ಕಾಯುತ್ತಿದೆ ಕನಸು, ಉಸಿರಲಿ
I request Dr. Shilpa and Dr. Sirish Shelvigi to moderate the session. First talk is by Dr. Jyoti Shetty. Madam, me.
ಸರ್ ಡಿಸ್ಪ್ಲೇ ಲಾಗಿನ್ ಆಗೈತೆ ಇಲ್ಲಿ ಡಿಸ್ಪ್ಲೇ ಲಾಗಿನ್ ಆಗೈತೆ PPT.
So, good afternoon, everybody. After a good lunch, I think you should all be back to the next glaucoma session. We have our next speaker, Dr. Jyoti Shetty, who again needs no introduction. We are all blessed to be her students, and she has been a very good mentor. So, her topic for today would be how to fine-tune the trabeculectomy.
Is there somebody who can help if, give the information outside that the session is starting, because many may not be aware of it?
ಚೇಂಜ್ ಮಾಡೋದು ನನಗೆ So I'll stand far away. ಇದು ಅಲ್ಲ, ನೆಕ್ಸ್ಟ್ ಇದು ಅಲ್ಲ, this one. Good afternoon, everybody. Respected members on the dais, the organizing members of the Tumkur Ophthalmic Society, Dr. Sanjay, Dr. Bhanu, thank you for the honor. So my talk is fine-tuning your trabeculectomy, a step-by-step guide. I've kept it very basic so that you can take home at least some tips for polishing your trabeculectomy surgery. Now, trabeculectomy still is the most widely done incisional glaucoma surgery in our part of the continent. However, the results are still not as standardized and as definitive as cataract surgery. The indications for trabeculectomy remain the same. If you fail to achieve your target intraocular pressure with maximal medical therapy plus minus laser, again, which doesn't work in our eyes, when you need to achieve a lower target IOP because of progressive optic nerve head damage in spite of being on maximum medical therapy, and if the patient already presents to you in advanced disease, where the patient is already having tubular fields with split fixation, you don't have the time to run through the traditional paradigm of waiting for the maximal medical therapy to work and then offering surgery if there is progression. There is very little to progress here, so you have to offer trabeculectomy as your initial treatment, of course, after bringing the intraocular pressures under control. And of course, relative contraindications to medical therapy could also be indications for trabeculectomy. Now, there are certain fine tunings that you can do in your trabeculectomy, and with these modifications, you can then achieve a bleb which is ideal. That means it is a large bleb, it is diffuse, of moderate height, posterior flow, and with a well-formed chamber both centrally and peripherally. If you can achieve this post-operatively, then your fine-tuning of your steps has really worked. And this can be done by various steps, which I will run through in the videos. Now, your fine-tuning starts right before surgery. So in your preoperative strategy, if the patient is on miotics, please stop them at least 1 week prior, because this causes the lens iris diaphragm to move in front, and that can compromise your postoperative results. If your patient is on PG analogs, that causes a lot of conjunctival hyperemia, and if it is permitted, you may stop it. If your duration of prostaglandin analogs has been for less than 6 months, then you can stop it for 1 week prior to surgery. If it has been more than 6 months in duration, then stop it at least 2 weeks prior to surgery. This is a rough guidance. Now, all these patients have been on multiple drugs, so definitely the ocular surface is highly inflamed. You could consider giving the patients low-dose topical steroids and/or cyclosporin to control the inflammation. Now, glaucoma is a disease in an aging body. It's a disease in an aging eye. So most of your patients will be on concomitant and anticoagulant therapy. So what do? They'll be either on warfarin sodium or antiplatelets. Now, the risk, all these increase the risk of intraoperative, postoperative bleeding, which can again, including the dreaded complication of suprachoroidal hemorrhage, which can compromise your results. And if you discontinue them, the patient will have thromboembolic phenomenon. So what do? You discuss with your physician. If you can stop the therapy, then warfarin sodium needs to be stopped at least 3 days prior. And at this time, usually they'll cover them with low-dose heparin after monitoring the INR ratios. And aspirin has to be stopped roughly 1 to 2 weeks prior. Now, regarding the or the intraoperative steps which you need to fine-tune, selection of the site. Always select a site where the conjunctiva is freely mobile. You don't want to dissect where the conjunctiva is scarred, because there'll be difficult dissection and it will also induce a lot more fibrosis. You need a safe anesthesia. Peribulbar or retrobulbar anesthesia is an absolute no-no. Do your cases under topical anesthesia after supplementing it with a local infiltration of lignocaine with or without adrenaline at a site which is away from your flap, because you don't want the buttonholes in the area of, or your puncture wounds in the area of your filtration, especially if you have used mitomycin C. Now, exposing the superior area is very, very important, because you do your trabs either superonasally, superiorly, or superotemporally. And the best vector force is achieved with a corneal traction suture. That taken with a 80 nylon suture, it will give you the best traction and the best exposure. Avoid brittle superior rectus sutures, because those two puncture holes will affect your filtration. If there is a subconjunctival hemorrhage in that area, it will again add to your complications post-operatively and a non-filtering bleb. Now, the most important step is making your conjunctival flap. You want to aim for a thick posterior diffuse bleb. You don't want this focal anterior ischemic bleb or a cystic bleb, which is limited by this scar out here if you take a fornix-based flap, a limbal-based flap. So that is why probably a fornix-based flap is a better strategy, because it is more posteriorly based. And this is how you take it, just in the area where you want to do your trabeculectomy. Make some side cuts so that you get access to the posterior area like so, and do a good dissection by just blunt dissection posteriorly, reach right to the superior rectus or where your muscle incision is. So these are the side cuts that you can do rather than taking a big incision from ear to ear. So that's how you fashion your conjunctival flap. It's playing again. Sorry. The cautery has to be extremely minimal so that you don't cause any scleral shrinkage, and it might be then difficult to suture your flap, especially when you're dealing with myopic eyes and young eyes. Now, the scleral flap, the shape is absolutely immaterial. Whatever works in your hand, rectangular, triangular, please go for it. But what is important to remember is, this is the step where your fine-tuning is most important, because this is the one that gives you the main resistance to the aqueous outflow in your initial stages, where the configuration of your bleb has to be really good. So your flap, whatever, so the flap that you make should be adequate in size. So probably what is adequate in size would be 5 by 5 mm, because your internal ostium is about 2 by 1 mm, and you want an additional 1.5 mm on either side for coverage of your internal ostium. Now, when you make the scleral flap, this point is very important. See, what I showed you is this should be 1 mm beyond the limbus. You don't want to take your incision right up to the limbus. That will give you a more anterior filtering bleb with all its complications. Now, how do you judge the thickness? Sorry, I think I need to restart 1 second. Now, so I think I told you about the slide. Is it working? Yeah. Now, how do you judge the thickness of your flap? Ideally, you want to make a 1/3 thickness of your flap. Now, it's very easy to say 1/3 thickness, but how do you graduate it on table? So there is a small trick to this. You take a 15 number blade. The width of the bevel of your 15 number blade, I'll just show it, see this width of this bevel is about 1 mm. So your sclera is always slightly more than 1 mm thickness. So you make your flap the usual way. Sorry. It just doesn't play where I want it to. It starts again. Is there any way I can just forward this? Just start there. Yeah. No, don't start from there. Start from somewhere in the middle. It doesn't work. Okay, I'm sorry. You have to go through it. So then when you make the groove on your sclera, you make it with one uniform cut of your blade so that you have the same uniform thickness throughout your entire groove. And this I have already told you. Can you not play it further? I mean, this is just wasting time. Can you do something? No? All right. You have to. Sorry for that. When you carry on the dissection at the limbus, you have to uncover your blue zone and your gray zone. Your blue zone is the one that is overlying your trabecular meshwork, and the gray zone is overlying your clear cornea. This is what I told you. The width of this is about 1 mm. You can measure that and see it on your caliper. So this, when you say a scleral flap 1/3 thickness, so when you put this in the groove, if it goes about half thickness, so you're somewhere between 1/3 and half thickness. So that's a rough idea on getting the thickness. Otherwise, it's something very casually told, make a thin flap or a thick flap. You don't know what is thin and what is thick in your patient. Cross it on either sides here, because the lifting of the apex is important. Can we not speed it? Okay, yeah, because otherwise we start again. We have done it already so many times. So keep your blade at the same uniform plane so that you get the same depth throughout your entire flap. Yeah, so there you go. That's the blue zone that has been uncovered. You can see the white line here. So then you start the clear corneal dissection to uncover the clear cornea. That is going to form your gray zone. I'll just show that to you in a moment. So that's the blue zone, and that's the gray zone there. And this is where your scleral spur is going to be there. Okay. So this dissection of your anatomy is the most important step. Now, use of antimetabolites is another thing that is going to control your filtration. I use my antimetabolites in all my cases, because these are patients, the patients who require trabeculectomy are your patients who are having tubular fields and split fixation. So you need a very good controlled filtration. Now, I prefer mitomycin C The ideal time on dosage is unknown, but you build your own technique by having a consistent technique. I use about 0.2 milligram per ml concentration when we have moderate cases, and I use about 0.4, not 0.5. That's a mistake there when I have severe cases. And the technique of application, sorry, you have to give me some more time. Not my fault. You apply it with PVA sponges. Don't use the methyl cellulose sponges because the methyl cellulose sponges shed. Apply it over a wide area, so the entire area you want a posteriorly directed flow. So apply it over a very, very wide area. That is most important. Okay. A paracentesis before making your initial and your internal block is very important because you want to lower the intraocular pressure before you enter. The internal sclerostomy, like I said, even 0.5 mm is adequate, but the size of the Kelly's punch, it will give you about a 0.7 punch cut. So 1 or 2 Kelly's punch will give you about 2 by 1 mm internal ostium opening. So that is the guide for you. So that's how the internal opening has, the corneal entry has already been done, and just make your Kelly's punch. This should be the ideal length. What is important is to see this coverage here and the coverage here. It should be adequately covered by the scleral flap, which will give you better blebs. You can also do it with a blade if you do not have a Kelly's punch. Iridectomy again has to be wide and basal. It should uncover your entire ostium. There should be no pillars of your iris clogging your internal opening. So once you cut off your, do the iridectomy, see that it should be there throughout your internal ostium. Now, one of the game changers in the filtration that you can achieve is by using releasable sutures. This is the one that is going to regulate your outflow till the healing occurs. So that is why using releasing sutures is the way to go in all these patients. Adjustable sutures have got their own problems. You cannot use it when you have a thick tenons. Laser suturalysis, not everybody has access to the lasers. So releasable sutures is probably the way to go. Put all your sutures as releasable or put 2 and 1 fixed. The choice is totally yours. The releasable sutures, I always put the apical suture as a fixed suture. If I try this again, it will go back, right? Yeah, so let's do that. Now the releasable suture, you start with a clear corneal bite. Can I speed this? No. So typically 10-0 nylon is used. So the first corneal bite, which is going to keep your suture buried in that tract. Then you go through the clear cornea. Come out in the area where you want to suture your flap. Exactly there. And then you close your flap suture. You try it with 3 throws or 4 throws. I find the 4th throw not extremely bulky. Though textbooks describe that, I usually use only 3 throws. So 3 throws and then lock that suture. Demonstrate that it can be released on table by pulling it before you close it. Okay. And you use a tighter flap if you have congenital glaucoma patients, because these tend to have post-operative hypotomy more commonly, even angle closure glaucomas. If there is a history of malignant glaucoma in the other eye, in myopic individuals and in non-ophthalmic eyes. In all these peoples, you close it down very tightly. Now the release of the suture timing, as long as if you have good bleb height, you have low IOP, don't release. First to 2 weeks, actually just give a digital massage and try and raise your bleb. You release it. If at all you want to release it, then release it with after 2 weeks. If you have used no antimetabolites and you have ample of time, even up to 4 weeks to release if you have used antimetabolites. And when do you release them? Whenever the pressure is high and the bleb is flat and your digital massage has not raised the bleb. This is how you release. You just pick up the clear loop and release them. Now the conjunctival closure is the next most important step. I use Vicryl to close the conjunctiva. So I use the reverse matrix technique. This has to be absolutely watertight. So no just bringing down and just putting 2 wing sutures. Believe me, if you want to moderate your bleb post-operatively, the only way to go is by putting, by having an absolute watertight closure out there. I won't show the whole thing because we are running out of time. Some simple guidelines on how to avoid wipeout because you're dealing with all end-stage glaucomas. Wipeout is irreversible loss after surgery due to no obvious cause. There is no macular edema, there is no hypotenuse maculopathy. Rare, about 0 to 7% cases, I have still not seen a wipeout syndrome. And various techniques to avoid this, you starts from your anesthesia. Don't give peribulbar anesthesia or retrobulbar, which can damage your nerve. Avoid severe fluctuations intraoperatively as well as post-operatively. Bring down the intraocular pressures pre-surgery with oral or IV hyperosmotic agents. On table, do a very slow paracentesis. Remove all your viscoelastic thoroughly, and use releasable sutures so that you have a tight closure at the end of your surgery and you can release the sutures as you want. So post-op complications are the least with this. Avoid post-operative spikes, give them judicious steroids, and keep them on oral agents like Diamox for few days if you're worried about them. So in conclusion, fine-tuning your steps of trabeculectomy will decrease the failure rate, decrease the sight-threatening complications, will give you a more acceptable safety and bleb survival rate. Thank you.
Thank you, ma'am. That was just a very elaborate and very informative talk on most commonly performed trabeculectomy. So, if any questions are there, we'll take it at the end of the session. Now I call upon Dr. Suresh to talk on medical management of glaucoma to achieve target pressures. Dr. Sirish Nelvigi is a renowned glaucoma surgeon and is a medical director and consultant at Nelvigi Eye Hospital, Bangalore.
Yeah, okay. Can you hear me? ನಾನು ಅನ್ಕೊಂಡೆ ಮುದ್ದೆ ತಿಂದು ನಿದ್ದೆಯಿಂದ ಸದ್ದೇ ಇಲ್ಲ ಅಂತ. Okay, so but still it feels like Auroville where there is a light coming from top and everybody is like, you know, in that transcendental meditation, and we have topics like this which can aggravate that. So the topic is how to determine the target IOP and also medical management. These are two topics by itself, but I have tried to minimize so that I can try to finish as much as possible in the next 15 minutes. So there are 4 shortcuts when we want to manage glaucoma. One is to establish the proper diagnosis, setting the IOP desired, choosing the medications and monitoring progression. This is how the flow of any management of glaucoma stands. You identify whether it's glaucoma or not. Next, choose how much IOP you want to keep and choose the medications and then monitor the progression accordingly. So to establish a diagnosis, you need to have comprehensive eye examination. This is the most crucial thing. There is no substitute to this. There is no shortcut here. So what does this comprehensive examination consist of? The routine things, what you all know: slit lamp, Goldman applanation tonometry, gonioscopy, etc., etc., and most importantly, optic nerve head and RNFL analysis. So here, one point I would want to highlight. I personally, not just as a glaucoma specialist, even as an ophthalmologist, I feel Goldman applanation tonometry is not replaceable. If you think I can still use my shots or any alternative, NCT though is totally out of the equation when you want to manage any patient. So I am highlighting the fact. I am not talking as a glaucoma specialist. I am talking as an ophthalmologist. Lot of misdiagnosis happens because you do a diagnosis through eye care or NCT. I would strongly advise against that. So next comes all the routine tests that you have, the visual fields and the RNFL. So since that is out of the scope of the topic here, I am not going into those. I am jumping into this specific topic as how you have to set the target IOP. So what is the target IOP? The IOP at which we believe that we can minimize the pressure-related component of glaucomatous damage. It's as simple as that. So that we believe is again a crucial factor here. So if you, what it also means when I highlight that point is, you have to understand by that word we believe that it becomes suddenly an abstract thing. The target IOP becomes abstract, and that is what it is. Target IOP setting is also a dynamic process. What is meant by dynamic is you cannot set one target IOP and say this is final. It can keep changing. So is there an algorithm to set the target IOP? The answer is a straight no. There is no algorithm. There are just indications and helps and pointers towards how you should set the target IOP. But however, just because whatever I'm telling, everything is appearing arbitrary now. I'm telling that it's arbitrary number, it is dynamic, it keeps changing, and then there is no algorithm. But however, this does not bring down the importance of target IOP. In fact, without setting the target IOP, I think you do not have anything to go by. You do not know where to end your medications. You do not know where to target your medications. So what you have to do is always enter your target IOP on your case sheet. As of say, for example, 2024 February, you enter it on the case sheet. So 18 is the target IOP. Keep on monitoring the patient over a period of time, and then you can keep changing later if necessary. So what are the factors which you use to determine the target IOP? These are the 5 important things which you need to keep in mind. I want to go back. It's going forward. Yeah. Okay. So one is the amount of damage due to glaucoma. I think the mouse is better. Yeah. So the glaucomatous damage, if the glaucomatous damage is early, you can get away with a higher target IOP. If it's advanced damage, you need to keep the target IOP low. If a patient is going to have a long, if he's going to live very long, you are expecting that, you need to keep his vision running for 30, 40 years. Right from the beginning, you better keep a low target IOP. And the untreated intraocular pressure at the presentation, if it is a low untreated IOP, you can keep a lower target IOP. I'll come to additional risk factors. Rate of progression, if it is fast, then you need to have a lower target IOP. So what are these additional risk factors? The additional risk factors are something like, family history of glaucoma, whether the patient has pigmentary glaucoma, pseudo exfoliation, any risk factors that, add up to that, even hypertension for that matter. When you have additional risk factors, you might need to keep the target IOP lower. So using those 5 parameters which I told you, you determine what the target IOP is going to be. So there is some rule of the thumb which you can use approximately. You can think of something like a 30% reduction for mild cases, a 40% reduction for moderate cases of the intraocular pressure, and about 50% for severe cases. But however, this is oversimplifying the problem. Now, obviously, if, for example, if the intraocular pressure is say 50, if you bring it down by 50% also, it is still 25, which is very high. So it doesn't work that way. So this formula, what I told, it's not even a formula for that matter. This guideline will work when it is in a reasonable range, like say, for example, 20, 25, 30. Then this works to a small extent. But however, this is just to give you an idea. You cannot use this formula and put your target IOP. So this is a slightly better way of understanding or setting the target IOP. This might give you a more realistic view of it. So you can see the intraocular pressure, as per the scale here. If it is a suspect of glaucoma, even if you have a pressure of around 21 to 24, it should be reasonably okay. Early stage glaucoma, somewhere around 18 to 20, 21, somewhere there, a target IOP setting should be okay. A moderate stage glaucoma, something between 13, 16, 17 should be okay. If you see, there is no line which is drawn there. So even here it is an abstract value. You have to remember that. Advanced stages, you need to keep the target IOP much lower. So here multiple readings, especially in low tension glaucoma, are needed to set the baseline IOP. Unless you have a proper baseline IOP, you can't go on setting the target IOP, and you have to take the highest IOP into consideration. So there are certain risk factors for progression, like age, life expectancy, large fluctuations of IOP, poor follow-up, axial myopia, family history. You need to keep these into mind and then adjust your target IOP accordingly. So you need to assess after setting the target IOP after a few years, maybe 1 year. Keep on doing the visual fields every 6 months or a year. Then see what happens to it. If you have a visual field graph, something going like that, then you are clearly off the serious visual field loss problem. And then, this is the age. So as per the age, you are not in threat of losing the vision before he is, you have a target age also, or life expectancy. You expect that, he's going to be alive for about 80, 90 years. So it's not going to deteriorate before that. You can just maintain the therapy. If you think that the graph is going something like that, you might need to increase the treatment a little bit so as to blunt the graph a little bit more. If the graph of the visual field is going like that, then a radical change of treatment may be required. A target IOP of 20 may need to be brought to something like 10, 12. So there is a benefit definitely of lowering the target IOP. Now, for example, if the target IOP has been set at 17 to 18 millimeter mercury, 18 to 19 millimeter mercury, it has been found that about say 30% of people will still progress. So whereas if you bring the 17 to 18 to roughly about like say 14.5 or 15, then the number of people, if you bring it down by 3 millimeter mercury, so the 29 suddenly becomes 7%. So that is the amount of change in progression that you can achieve when you bring down the intraocular pressure to a decent level. So now this is a algorithm which you can follow. Once you have determined the target IOP, prescribe the treatment. If you see after 6 months the patient is stable, you can just go on, you don't need to reconsider the target IOP, you can go on continuing the same target IOP. Suppose there is progression, you need to consider to lower the target IOP. This check of whether progression is happening or not happening is tied to setting the target IOP. So when you see that progression is happening, that means you need to readjust the target IOP. If there is no progression happening, you can continue with the target IOP. It's as simple as that. So now coming to the medical management, the medications what you use. Again here, I am going to give you very arbitrary and approximate ideas about how you have to approach the medication and which medication to choose. I am trying to keep it as simple as possible, given the constraints of the time for me. So now with a 20%, if you need something like a 20 or 25% reduction in the intraocular pressure, you have the two common first drug choices which are available, which are the beta blockers and the PG analogs. If cost is not a factor, then PG analogs should be the first choice, even if you require a 20% reduction in IOP. Though the PG analogs may achieve much more than that, but you also need to consider the safety of PG analogs is extremely high. Beta blockers, when the cost comes as a major factor there. When you need about 35% reduction in the IOP, then PG analogs are the obvious choice to you. You have all the 3 or 4 available, latanoprost, bimatoprost, travoprost, etc. All of them are more or less equally efficacious. So as far as possible, don't use in inflammatory glaucomas, and they are the most preferred line of treatment in non-inflammatory glaucomas. When you require more than 40% reduction in the IOP, no single drug can achieve this. Here you have to go for combination therapy. So combination therapies are also cost effective and easy to put, and compliance of the patient is much better. So when the intraocular pressure was reduced, so according to the advanced glaucoma intervention trial, so the least amount of visual field defect change was seen with the IOP of around 12. You can see this flat graph of visual field change. So if you have an intraocular pressure which was set at average of 20, you can have a visual field change which is about like 2 to 3 decibels, which can happen on an average. So therefore, if you have a very advanced glaucoma, it makes a lot of sense to keep the intraocular pressure as low as possible, because you don't have too much time to keep experimenting with this to see if it is stable or not. So dosage, beta blockers are twice a day. Alpha 2 agonists can be 2 to 3 times a day. Ideally, they are 3 times a day. Dorzalamide again is 2 to 3 times a day. PG analogs are once a day. Now we have the ROCK inhibitors. ROCK inhibitors are between 1 to 2 times a day, whether you are using netarsudil or ripasudil. Systemic drugs are used only when the intraocular pressure is very, very high, beyond the range what the medications can reasonably bring down, the topical medications. Side effects, beta blockers, you need to remember some very, very important points. Dryness of the eyes, itching is all common, but bronchospasm and cardiac problems are what you need to keep in mind when you initiate beta blockers. PG analogs largely have cosmetic issues like hyperemia, trichomegaly, darkening of eyelashes, but there are some very rare things like, formation of viral dendrites can be aggravated, cystoid macular edema. Some people also do have a tendency to get aggravation of the backache with PG analogs. They are not common, but you need to keep those in mind. Brimonidine is quite dangerous in children. Obviously, you can't choose that. So about 12, 14 may be a better choice. Drowsiness, loss of concentration and hypotension can be very common. Hypotension can be one very, very important and crucial problem, especially with brimonidine. I've seen people getting admitted in ICU with hypotension just with 2 or 3 days of brimonidine treatment. Dorsalamide main problem is burning. So now most important is an information pamphlet and good education and counseling to the patient needs to be given. It's always very important to have a good approach to the patient and explain them whatever you are doing and give your time, especially in the first visit, till the patient understands the problem. Praise the lower IOP in the follow-up visits and keep on encouraging him. I'll just end it with some 3-4 examples if I have 2 minutes. Sorry about that. So here you can see a 52-year-old techie. So you can see that over a period of time, this is roughly about say 8 years, 5 to 8 years of follow-up, which you can see here. You can see the visual field is very, very stable. When you are seeing a visual field so stable as this, you know that you are doing something correct. So whether you have achieved the target IOP by means of giving medications to the patient or by way of surgery does not matter. The target IOP is achieved, and this is the kind of visual field.
Like Tata AG car insurance. Online jao, policy purchase, renewal,
you can see the lower left eye visual fields, which is progressing over a period of time. He was controlled almost for 5 to 6 years. He's a billionaire actually. He's a multi-millionaire rather. He's a manufacturer of all this Britannia breads, biscuits, all those. They own a lot of factories. But then money can't stop glaucoma. Neither can it stop Alzheimer's and Parkinson's as it did in his case. So if you see till 2019, I had a reasonable target IOP, which I thought was working very, very well in the beginning. You can see till here it was quite stable, but suddenly you see a deterioration happening from this point onwards. So here you need to reset the target IOP. But here I am putting it as a case example. If I need to reset, there was an onset of Alzheimer's and Parkinson's simultaneously. He was in a very bad shape. Walking was difficult, remembering was difficult, there was a caretaker involved. Now I know that when given this situation, he's not going to live probably very, very long. After that, you need to be very practical. You don't need to keep it at 10, 11, put him with overdose of medications, cause the side effects of medications. Again, if you put beta blockers, you will go into further depression. So keep those also in mind when you want to set the target IOP. This is another software company owner at 78 years. It's again a very, very, very slow deterioration. If you see, it's an extremely slow deterioration. If you see from the initial graph to the last graph, you will probably able to identify that a slow deterioration is happening. Given the age that he is 78 years, even if there is this slow deterioration, it's still okay whatever pressures you have, even if there is no complete control over the visual fields here. That's because his life expectancy is not going to go very, very high. So I think I'll probably stop at this. I had another 2 examples, but I have overshot my time. So in brief, controlling the intraocular pressure, achieving the target IOP are all abstract things which you need to keep on verifying at timed and scheduled intervals, keeping on seeing what is the progression happening. So remember the last word which I am telling, everything is tied to progression of the patient. Most of the things rather. So based on the progression, you are going to adjust everything, the medications, the target IOP, and how you are going to manage the patient. Thank you for being patient.
Thank you, sir. Thanks a lot for that wonderful cases showing stabilization with treatment. So any questions from the audience?
See, it is too early in the phase of introduction of the drug for me to give a very authentic comment or a confirmed comment to you. Because it's just been introduced about say 4 months back. I have used it in probably about say 10-12 patients. I have had a mixed bag experience here. I have had at least 2 to 3 patients where after shifting them to a 3-drug combination, I had to shift them back the split way what I used to do initially. I have had a couple of patients where the intraocular pressure slightly went down more than what was happening with the 3-drug separate combination also. Some patients there was no difference. I had one patient who could not tolerate also. So I am talking to you only within the 15 patient range approximately, that what I initiated the treatment on. I think if I need to get a proper idea about how well this is working, I would need to see it being introduced in something like about say 150, 200 patients. Then I can give a proper idea. There was a study done locally also. I think, I don't know whether the company has revealed it or not. I'm not sure. We were privy to some information. So according to that, there were it was exactly the same mixed bag experience that I get was visualized there also. There were a lot of fallacies in the study where proper washout was not done and all that. So therefore, I think we need to wait for some time before we can understand.
Just one comment here. Whenever you use a fixed dose combination of 2 drugs, 3 drugs, whatever it is, you should have demonstrated individually that each drug is working for this patient. Okay, and in most of the mild and moderate cases, you have the time available to you. In your severe glaucoma cases, again, you have treated them for quite some time. So know that each individual drug is working and only then give. Otherwise, you are adding on to the toxicity in the eye. Yeah, in neovascular glaucoma, your threshold for surgery is very low. You don't want to wait because those are very high pressures which you are dealing with. So you have to operate them much faster. Surgery also theoretically drains out a lot of the angiogenic factors. So you get better results there as far as the glaucoma control goes.
When you have the patient on 3 drugs, switch them over, see the IOP, then individually take a call. Don't, it's not like one blanket advice which can be given here. It varies hugely from person to person. Therefore, test it out and
Thank you, friends. Thanks for your interaction. I want the moderator's chairperson to be on the desk. I request Dr. Arun Samprati sir to go ahead with this talk.
Good afternoon, and as Dr. Sirish said, Ragi Mudde Uta is powerful. And if you're awake, we'll be discussing about myopia. First of all, I would like to thank the Tumkur Ophthalmic Society, especially Dr. Sanjay and Dr. Dinesh, for giving me this opportunity to talk about myopia. So today, if you see any gathering of children, you will see all children like this, all with glasses. So this is a very common sight now. And the incidence of myopia is just going out like Nifty and Sensex. So during COVID, Nifty was 7,500 and it has gone to 22,000 now. So similarly, the incidence of myopia has been going up and up. So you can see here this graph going up and up. So in 2000, it was only 22.9 billion children with myopia, whereas in 2020 it has gone to 33, and by 2050 it's supposed to go to 40, almost 50. So that's how. But when Nifty was going up, we were all very happy because we are making money. But we are very unhappy with this type of a progression of myopia, because if you see this high myopia, which is supposed to become the most common cause of irreversible visual impairment in children, almost by 2030, we are expecting 516 million children to be having this high myopia. So what are the causes for this sudden surge in high myopia? We all know one is the reduced outdoor activity, greater near work because all the educations have shifted to online, and prolonged use of digital devices. So we all know the impact of COVID, because after COVID, the children were within the 4 doors. They were not going outside, no sunlight, no play, and all the education was online. So definitely the incidence of myopia has increased because of the change in the platform, the way of education. The other important thing is, all these days we were focused, whenever we saw a child with myopia, we wanted to correct the refractive error, improve the vision, and prevent amblyopia. But nowadays there's a shift in the focus from just giving a correction to prevent the onset of progression of onset and the progression. So in fact, the onset itself, we are trying to prevent the myopia from starting. So that means that we should be continuously abreast with the latest what is happening in the field of myopia. So previously, the pathogenesis of myopia was exclusively genetic. Always we used to think environmental factors have no role, reading has no role. But nowadays there are a lot of studies which have proved that genetics is not the only thing. There are a lot of other factors, especially the environmental factors, which affect the progression of myopia. So now it is a complex interplay between the genetics and the environmental factors. So traditionally, this is something called as peripheral defocus theory, on which some of the newer myopia preventive measures have been devised on. So we were always, we know that the myopia most often is an axial myopia because of the increase in the length of the eyeball. So traditionally, when we give the correction for a single vision glasses, it corrects the central beam of light, whereas the peripheral lights are overshooting the retina, because the eye is not a perfect sphere, it is oval in shape. So these lights are focusing beyond the retina. So this has been proposed as one of the theories which can cause a progression of myopia. And that is how these peripheral DIMS lenses have been designed, so that the rays, peripheral rays, don't focus beyond the retina, and they either focus on or in front of the retina. The central rays are as focusing on the fovea. So this is the pathogenesis of how this peripheral defocus is inducing a change in the myopia. Other factors, the accommodation, higher order aberrations, the circadian rhythms, light intensity, all these things have a role. And these are the risk factors for myopia. Ethnicity, the Asians are highly prone for development and progression of myopias. Very high myopias are seen in the Asian population. Gender, the female gender. Parental myopia is a very, very important factor. If one parent has the myopia, the chances increases. If both the parents are myopic, then the chances of the child getting myopia is extremely high. As we all know, preterm infants and excessive near work are the factors which can cause the myopia. So expected progression, suppose if the onset of myopia is between 6 to 9 years of age, then it progresses approximately about 1 diopter in every year. And if the onset is between 10 to 13 years, the progression is 0.5. So especially during the puberty time, we see there is a sudden surge in the myopia. When there is a growth spurt, when the child's height increases, so suddenly we see that the myopia also increases. So our treatment also should be, we have to keep an eye on that. So whenever we are expecting the puberty to start, at that time we have to be more aggressive with prescribing this myopia measures. So if at all the myopia is there, what happens? Why should we really stop this myopia from progressing? So the most important thing here is the degenerative retinal disease. As I said, myopia is supposed to become the most common cause of preventable blindness in the world. So that is the reason why we don't want myopia to progress. Plus the cost of optical treatment, we know now the costs have gone up like anything. It affects the quality of life. Glaucoma, Dr. Sirish has already talked about it, and also the incidence of cataracts. So how do we stop progression? The current available modalities, one is the spectacle lenses. There are a variety of spectacle lenses I'll discuss. The pharmacological modifications are there and the contact lenses are there. But the most important is the environmental factors, which we are not focusing hitherto. So what are the environmental factors we have to take care? So we have seen that a lot of studies which has shown that there is increased outdoor activities will definitely reduce the incidence of myopia, and this is supposed to be through the release of dopamine. So light stimulated release of dopamine has been shown to inhibit the axial elongation. So that is the reason why there is a shift in focus towards outdoor activities. In fact, in some of the schools in Singapore, they have totally shifted to outdoor classrooms instead of indoor classrooms. And the other factor is the excessive close distance. So we have seen a lot of children now, they go very close to the screen and they keep seeing the screen for long hours, especially with the mobile devices, they tend to hold it very close. So this is one of the factor again has been proposed to be responsible for the progression of myopia. And in some of the schools in China now they have put a restrainer like this so that the child doesn't go very close to the book. Optical modalities, basically undercorrection was the initial modality, but however there is no evidence to say that this modality is beneficial. We have used some cases, we have used bifocals and progressive lenses. So this is very useful in children who have this accommodative lag. So this is how you check the accommodative lag. So whoever the child has this accommodative lag, in those patients, these bifocal and progressive lenses work very well. There is another new set of lenses based on this peripheral defocus theory, as I told you. These Hoya myosmart lenses. So basically, this has a central zone for the vision, the clear vision. The peripheral zone is having a hyperopic defocus, means they have a plus 3.5 addition in the peripheral area. So because of that, the rays of light, instead of focusing behind the retina, they are focusing in front of the retina, and this prevents the progression of myopia. On similar lines, Zeiss has something called as CARE lenses, and the latest is the SIMSRH, which has come out with the HALT technology. So basically, this is how the lens looks. There are almost about 1021 lenslets spread across 11 rings. So again, this has shown to reduce the rate of progression based on the peripheral defocus theory. On the same basis, we do have contact lenses. Orthokeratology is one of the other modalities which is very popular in Western countries and slowly picking up here also. Though personally I don't use it because I'm not very convinced with this theory of orthokeratology. So basically what happens is child sleeps with the lens overnight, and in the morning the child removes the lens, and the child is able to see unaided without any glasses. So how it works is, see, suppose if this is the myopia profile, when you put the ortho-K lenses, it is supposed to exert pressure on the cornea because the lid is closed during the sleep, and that molds the cornea, means basically it flattens the cornea, and that is how the child is able to see the daytime without any glasses. So this also has been shown to reduce the rate of progression, but there are very few studies, and personally I am not using it because I am not convinced with this the theory behind this ortho-K lenses, and also the complications which can happen especially in children. Coming to the last modality, the pharmacological, which has been the very popular modalities. How many of you are using atropine already? Oh, very good, quite a large number, yes. So that's very popular now. So atropine has been proved to be one of the best pharmacological agents to prevent the onset of myopia, and especially this 0.01%. 0.01% has been conclusively proved by this ATOM2 study, which has shown that it has very minimal side effects, and the incidence of rebound myopia, which is initially they used 1% atropine, and in that the problem was rebound myopia and the very blurred near vision, which required bifocal or progressive glasses. So whereas this 0.01% is very good, it doesn't blur the near vision, and the chances of rebound myopia are also very less. So how it works, it's definitely not through the accommodative system. It is supposed to have an effect on the muscarinic M1, M4 receptors, and probably some non-muscarinic effects. Probably we still don't understand the exact mechanism how it works, but it definitely works. And recently there has been one more study, the LAMP study, which has shown that 0.05 atropine works better than 0.01. So this is commercially still not available. I think Entod is probably coming up with 0.05% atropine. So once it's available, definitely in patients who progress still with 0.1%, 0.01%, 0.05 will be a better modality. So as I said, the side effects with 0.01 is very less, and I've been using from a long time now. Results are very good, and we can also use combination of these things, and this particular combination I've been using. Whenever atropine alone is not able to control, I add the DIMS lenses. So this is the flow chart, how we can go about with treating a child with myopia. So any child with a progression of more than 0.5 per year, you just check for the accommodative lag. If there is a lag, then you have to give them the bifocals or the progressive glasses. If there is no accommodative lag, then you can start with atropine 0.01%. If there is no progression, it is good. After 2 years, you can stop the drops. Observe for 1 year. If there is again a progression after 1 year, you can restart the drops for 2 more years. If 0.01% is still not working, we can try 0.05% whenever it is available, or we can try the combination with DIMS lenses. Nowadays, there is interest about this pre-myopes, because a child probably at the age of 6 years, if the hypermetropia after the cycloplegic refraction, it is less than 0.75, then these children are at a very high risk of developing myopia. So they have started treating pre-myopes so that we can prevent the onset of myopia itself. And there is an ongoing study now, the ATOM3 study, which is studying the efficacy of use of 0.01% in pre-myopes and high-risk children to prevent the onset and progression of myopia. I request all of you to read this wonderful article. It's published in the IJO, It is a group study. I was also part of this myopia group, and it gives a very detailed description about how to prevent the progression of myopia. So, in conclusion, environmental factors which are hitherto ignored is one of the very important factors which we need to remember, and it's a very promising intervention. We have to encourage children to go outdoor and at least 1 to 2 hours of outdoor activities in the sunlight. Even if your child doesn't play, if the just child stands in sunlight for 1 hour in a day, that itself is sufficient. And there is consistent the evidence to show that 0.01% atropine is really workful, very helpful. And in cases where there is still progression, we can try the combination of lenses. So care of myopia doesn't end with just the control of myopia. So these children are definitely prone for retinal complications, cataract and glaucoma. So we have to educate the parents and the child also regarding this, and ensure that we need to keep the child under follow-up, and also we need to update ourselves with the latest whatever studies are coming up. Thank you.
Thank you, Dr. Arun. Couple of quick questions from the audience. Anybody? For you, Dr. Arun, do you always start with drops first, then glasses if they don't work?
Yes.
Or
yes,
a combination together? Or are there any group of patients where you would start the glasses first?
Only if the compliance is poor, or if the child has some cardiac issues where we feel atropine might not be safe, only then I use glasses first. But unfortunately, what is happening is you give the prescription for glasses, the child goes to the optician, and they come back with the DIMS lenses. You might have not prescribed, but the opticians are very good in counseling that, and they are selling that. And normally, I don't prescribe this on the first visit. Suppose if the child comes for the first visit and I diagnose the child to have myopia, I'm not starting the treatment in the first thing. So only there should be a documented progression, 0.5 per year or more. So only then we need to start any of the interventions.
How frequently do you follow up your children?
6 months. Every 6 months is ever. Yes.
And every 6 months they go through the same cycloplegic.
Yes. It's compulsory.
I think that is the point that we wanted to highlight. So it's not nowadays casually atropine drops are started in everybody.
Yes.
There has to be a protocol that has to be followed. You have to be very careful of there are so many long-term effects that we have not studied.
Yes.
These children are there on these drops for 1 year, 2 years, 3 years, sometimes 4 years. So one has to be very careful when you use these drugs in very young eyes.
And I've seen doctors starting children with astigmatism on atropine. So atropine doesn't work for astigmatism; it only works for axial myopia. So you should be really careful with that.
Any questions from the audience, or shall we wrap up this session?
Sir, the studies have shown 5 to 6 years of the age, but I have started as early as 4 years also in children who are progressing. Yes.
And further than this, what is the earliest age that you have given the glasses for? Because that's quite difficult to adapt.
Glasses also 6 years. 6 years is the earliest
You have
age.
not given any younger.
Yeah, and it's easy. It's not that difficult, madam. It's actually very easy. And children are actually less fuzzy, and it's easier to treat a child than adult. So they get adapted very fast.
Have you done? Okay. Thank you, Dr. Arun, for a wonderful lecture.
Thank you, sir. One announcement. We are almost about to close the session. Anybody interested in visit stall number 1 to put your lucky trip. So, we facilitate the speakers, madam, please. I request Lavanya madam to Dr. Jyoti Shetty madam. Dr. Banushree madam. To Dr. Shilpa. Dr. Sanjay. To Dr. Selish Nirvagi. Dr. Sidling Swami. To Dr. Ram Santraji sir. Thank you, friends. We will move on to the next session. session on edema.
And welcome back to this US Open office plan.
Dr. Veerbhadra,
Lobbed a message way over Jones'
Dr.
head using
Tirumalai
some-
sir, Ganesh.
Thank you, Tumkur Ophthalmic Society and the organizers for telling me especially Manjunath. And the topic is try to manage post-op and off. So the most important part before you manage anything is first to make the diagnosis. So you make a diagnosis of to have a patient come in after surgery and to see a circumstantial condition or the media that is there, or the patient patient I had not entered the ICU. The lower patient actually was having toxic surgery, and the upper patient is intensive. And you can see that the edema is not very diffuse. There might be patchy edema if any, but there is more of AC reaction. In the second part, you can see that the cornea is diffusely white. So this is toxic anterior shock syndrome. Now, how to differentiate the endophthalmitis which you manage with antibiotics from a TARS which you manage by giving steroids? Is that usually you see TARS in post-op day 1. The cornea is end-to-end white. Pain is usually absent, but it's not that TARS never presents with pain because cornea is edematous. There are numerous nerve endings on the cornea which can have pain. So, pain absent is not a very classical thing to say. Yeah, that's what's mentioned. Diffuse corneal edema is the one which sets you on the on the right track that when the patient has so much of corneal edema, that is probably toxic anterior shock. And second thing is if you look at the patient, there is no vitreous opacities. But in patients of endo, you have all the others that I described in the previous slide. So ultrasound forms a very good investigative modality when you cannot see inside. If you do an ultrasound and if there is a vitreous opacity, irrespective of the corneal edema, err on the side of endo. Because toxic anterior shock syndrome is what exactly it means. It is in the anterior segment. There is no vitreous opacity. But if you have a bad cornea like that on post-operative day 1, you do an ultrasound, you find a single vitreous opacity that was not there preoperatively, it is endophthalmitis. So once you do this, it is very important to document because end of can be a end of the eye related event where the patient can lose vision. So document every single sign, symptom, and so that it becomes very important in following up to know whether the patient is becoming. Ultrasound is strongly recommended for posterior segment evaluation and also to make a diagnosis. In presence of a retinal detachment, you would go ahead with the vitrectomy and not try intraoral antibiotics. So ultrasound becomes important. Discuss the treatment options with the patient. They would come to us thinking that one surgery would help. But once there is end of, there might be requirement of multiple injections. Maybe you are going to repeat the injection over 48 hours.
and you are probably going to take a sample which might be repeated in a few cases. Now, visual acuity, if it is counting finger or better, then you can try what is called as tap or inject. What you do with the tap or inject is you tap both the vitreous and the AC tap. So AC tap and vitreous both can give you two samples for the evaluation. Send the sample for microbiology. Look for both grams and KOH. Many people think that KOH is the only one which can tell you what there is a legal IP or not. Even the gram stain can tell you that there is KOH. So usually results are notified within a few minutes. If you have the lab, an institute setting like this, or has a microbiology lab. So we have a facility which tells us within a few minutes. Based on that, we try to give them the injection. So I commonly follow this protocol. I usually use patient is reassessed within the next 48 hours, and if there is any worsening, I usually consider vitrectomy. And this is also a recommendation of the EVS study. Now, if you look at the grams, why I put up this slide is that you can do the microscopy within the OT. All you need is a slide where you can put the sample on, do an air dry and feed fix, which can easily be done. And after that, you can do a gram stain, which hardly takes 10 minutes. So on the gram stain, how do you know whether it is contamination or it actually is a infection? Is that you will see a lot of polymorphs which are there. Sometimes you can see the bacilli being the bacteria being within the polymorph. So that definitely indicates it's not a contamination. It is saliva being positive. The next one is a gram stain where we could diagnose a fungal hypha and gram-negative bacilli. It was a combined infection. If you add KOH with calcofluor, I think somebody was telling this that if you use two stains, the positivity rate is in excess of 90%. So over the past few years, we have also been practicing that and we plate it onto the culture media within the OT. So our slide and gram positivity rate is in excess of 95%. We also have this practice of doing conjunctival culture in patients who are one-eyed, and every sample that is taken from the vitreous is usually cultured. It did increase our knowledge, where we have provided what is called as the institutional nomogram, where or the antibiogram, where you have cultured 20 and you know what is the usual incidence and how sensitive they are if they come back to you. It tells you about the population that is visiting rather than it gives a good idea. So if microbiology shows fungi, then you go ahead with roconazole. If the microbiology says that probably it's bacterial, then you go with ceftavanco. If it is negative, then you use all three. So if the visual acuity is hand movements or PL, then if it is worse, then you go ahead with vitrectomy. Usually I do one port before starting the infusion. I usually remove the membranes so that the membranes can be sampled on the IOL, and then once both the ports are placed, I usually take an undiluted vitreous sample. Why it is important to take multiple samples is you have made multiple attempts at gathering a sample which is undiluted, hence your diagnosis becomes that much more accurate. Now, once you do core vitrectomy, how do you proceed? You debulk the vitreous as safely as possible. PVD is not usually attempted, but if PVD is already there, you do as much vitrectomy as possible. Once you start seeing the retina, you do a partial FGE. You can put the antibiotics at that point of time, and which antibiotics to use. Because you are doing vitrectomy for 30 minutes, you would have probably had the report by then. So the EVS was done to look at would intravitreal antibiotic when combined with either systemic antibiotics like using intravenous, or would intravenous antibiotics be better, or how about combining both? So what the study essentially said was that intravitreal antibiotics is very effective. Intravenous antibiotics do not have a role, and the second one was that that it told about commonly used use the same antibiogram what was there. So they recommended ceftazidime and vancomycin. So vancomycin covers the gram positive cocci, and ceftazidime would cover a gram negative kind of coverage. So I think I've discussed about the results, and I think I have a video in place. Thank you. If there are any questions, I can take it. We can do it at the end of it.
What would you say as the most important thing in prophylaxis so that they don't get endophthalmitis or any intraocular?
Okay, so a large study by Arvind actually said that you can use AC antibiotics at the end. I'm a non-believer in that. I believe that if you put betadine and give a good, good cleanse of the conjunctival cul-de-sac, I think you should be good. Majority of the times, what is grossly underestimated is that the incisions which are made should be watertight. If you ensure that, then probably postoperative endophthalmitis, you're not doing anything by putting an intracameral antibiotic, because the clearance of the intracameral antibiotic is within 2 hours. You have essentially, accomplished nothing by putting an antibiotic at the end of the. But the study does show significance, so I mean, it's for you to choose. But I am a non-believer in that. If you want to ask me a direct question, I am a non-believer. Whether it is a complicated case or a non-complicated case, I believe in tightening my, incisions watertight. I don't put antibiotics until I see something. Okay, so that's a good question, because TARS is something where there has been an abnormal reaction. It's kind of an idiosyncratic kind of a reaction. So what I do is I give them oral steroids. But to be on the safer side, that however confident I might be at making a diagnosis of TARS, there can be, a small predilection that it might be endo. So I usually give them oral antibiotics as well. And I increase the steroid dosage to 6 times. I normally give about 4 to 6 times steroid dose in the postoperative period. In TARS, I would give it once every 2 hours.
Normally, prevention is the best thing, because most of these infections we see with the solution which we use, PSS or whatever solution we use. I think nowadays we see less number of endophthalmitis. Probably the operative conditions are improved, and also the number of camps what we do is in a better conditions, less camps, and also PSS what we use is a better one now. Still, there is a possibility always. Most of these endophthalmitis in camps and all we see with PSS, what we use. So I think there we have to be very careful. And whenever there is a post-operative reaction we see, we always first we have to think about endophthalmitis only, more than TARS. I think once there is a reaction, we have to be very careful, closely follow it up. And whenever there is a doubt, I think the early intervention is very, very important. So earlier days in EVS study and all, there were old days and people were thinking still wait to vision to decrease significantly and then go for the surgery. And nowadays, a significant reaction when we are not aggressively increasing. Many times some of the organisms increase so fast, you don't have time. Like, instead of waiting, early vitrectomy is always a better one. So do a vitrectomy, proper vitrectomy. If the recent infection, the retinitis or retinal damage will be lesser. In such situations, go for a PVD induction and completely remove the vitreous, and then that will solve most of the problems.
More on that. Yes, we do vitrectomy. It may be better to use silicone oil as well, because it's known to have some anti-infective properties.
Correct. I agree with you. So if the infection is pretty severe, you see that extensive area of retina is edematous, or if you see perivascular infiltration, silicone oil is a good idea to use. I do use it. Correct.
Take any precaution because that frequently causes TARS.
You're right. So many a times people do feel that you should make sure that the tubings are washed properly and they're sterilized properly. So the indicator on this thing. So if you have found that it is properly brown, then yeah, why not go ahead.
The thing is to wash it at the end of the surgery, immediately after the surgery. If you leave it, then it tends to get stuck to the instruments and doesn't go away by washing. So that's
And
why
before-
you tend to get more of these.
Yeah. Properly wash, properly dry, and also we do a ultrasound cleansing of them before we send them for re-sterilization.
Antibiotic.
No, we don't use. We don't use. Thank you. So I'd like to invite Dr. Ravi. He'll be talking to us about evaluation of retina before cataract surgery. So Ravi is a assistant professor at Minto, and he's also passed out from RP Center.
Good evening, everyone. So I'll be presenting on the fundus evaluation before cataract surgery. So it's a very, very important aspect when you are dealing with cataract patients. So it's always important to ask for 6/6 vision. If the patient is having a cataract and a low vision, you should always correlate the amount of cataract and the vision. Is it correlating? If not, you should always rule out any pathology before proceeding to cataract surgery, so that you can avoid a lot of post-operative interactions and discussions with the patient, and patients will go happily. At least you already priorly informed the prognosis about the visual prognosis of the surgery. So what is the need to evaluate the fundus is to assess the visual potential, to adequately counsel the patients regarding the potential visual potential when the visual outcomes in these times where the patients expect 6.5, 6.4. So they will ask, why not 6.5, why not 6.4? So this is a time where the patients are very demanding because they are paying. Even the camp patients also ask, sir, I don't want to use spectacles. So that the times are gone that where they were like, okay, if you get some ambulatory vision, it's fine, but the things are not like now. Okay. So then to decide whether to go ahead with the surgery, cataract surgery. Okay, so what are the instruments to evaluate the fundus? So it's always mandatory to have all these instruments when you are dealing with a cataract surgery or any clinic. It's not very costly and it will give you a lot of information of the retina. So indirect ophthalmoscopy is a must. It's not very difficult. You just need some practice. Okay, using a 20 diopter lens, and we have a direct ophthalmoscope and then slit lamp examination with the 90 diopter lens. So what are the findings or points you should look in the fundus is right from the optic disc, macula, vitreous, retinal vessels, and the periphery. So always important to look for the color of the disc, the size, the shape, the cup disc ratio, disc margins, peripapillary area, and the neuroretinal rim. So it's a good idea to have a baseline visual fields before the cataract surgery in a glaucoma patient if the media allows. Okay, so then document the increased CDR, abnormal neuroretinal rim. Okay, intraocular pressure should be recorded. If it's high, it should be controlled before doing a cataract surgery. Okay, then RNFL, if you have OCT facility, it's a good idea to have a RNFL OCT to document the RNFL thickness. Then optic neuritis, first treat the optic neuritis before taking up a surgery. So when there is a bilateral disc edema, look for a papillary edema and rule out the cause before doing a surgery. So this is a case of there is a first image there in glaucomatous disc, and the next image showing an disc margins with the hyperemic discharge of a optic neuritis. So in a pale disc, always have give a guarded visual prognosis. Coming to the macula. So if the media is clear, always assess for any macular disease like a cystoid macular edema, serous retinopathy, then age-related macular degeneration having a drusen, dystrophies, macular scar, epiretinal membrane, so on. Okay. So coming to the cystoid macular edema, it's very important, especially we see a lot of patients with diabetes. So they may have some amount of diabetic retinopathy with cataract. So both will contribute to the vision loss. So we should always assess whether cataract is more or the diabetic retinopathy is more. Okay. So always it's the best good idea to grade the amount of the severity of the diabetic retinopathy. So along with then you can also have an OCT look for the macular edema. So if there is a macular edema, it's always a good idea to treat the macular edema because cataract surgery means it's inflammation, it can aggravate the macular edema. So then patient can have worse vision. So it's better to treat. You can treat first macular edema and take up for surgery if the cataract is minimal, or if the cataract is advanced, then you can do the cataract surgery, or you can combine the cataract surgery with your intravitreal anti-VEGF or steroids. This is a OCT image showing a cystoid macular edema. You can see the cystic spaces in the outer flexible and inner nuclear layers. And this is a fundus image showing a succinous retinopathy with hard exudates, and it's kind of a parafoveal involvement. So these are the various causes of cystoid macular edema. So when there is a situation, you should always see whether it's a vascular cause or because of any drugs or an inflammation, okay, or a dystrophy. Then coming to an important cause ARMD, because most of these cataracts develop at an older senile age, so the animals have some amount of age-related macular degeneration. So look for drusen or a PVD. Dry ARMD is better prognosis compared to wet ARMD, where they may have CNVM, active CNVM or a CNVM scar, where the prognosis is guarded. So you can see here there is an early to an intermediate to advanced dry ARMD, and there is a geographic atrophy. This is a case of CSR. Usually CSR occurs in younger age, so usually younger age the cataract is not there. So there are not much guidelines about CSR and the cataract surgery. You can go out with the cataract surgery. Okay. So this is an image showing in the left there is a you can say active CNV with the subretinal bleed, and there is a macular pucker showing an epiretinal membrane. There is a full thickness macular hole, and there is a case of a macular dystrophy with the foveal thinning. So all these cases the vision is guarded. Coming to the vitreous, look for any PVD, vitreous hemorrhage or any vitreous opacities or degeneration. Incomplete PVD, the risk of tugging on the retina and causing retinal breaks after surgery, because when there is a cataract surgery, so that it can cause an early induction of PVD, so they can develop a symptomatic PVD and a retinal tear. So it's always important to follow up, or if there is any sudden onset of floaters or flashes, so always you should look for the periphery to rule out any retinal breaks. Complete PVD, so there is less traction on the retina, so the risk of retinal breaks is less. Okay, so vitreous degenerations, floaters, astrodialysis, usually they don't much affect the vision. Yes, if there is a severe dense astrodialysis, we can consider vitrectomy. So this is showing a beautiful V's ring suggestive of a complete PVD, and the bottom is showing a fractional bands with a proliferation suggestive of there is a vasoproliferative disease. Okay. So then coming to the vitreous hemorrhage. So first you have to always assess the cause for vitreous hemorrhage, why the patient has developed vitreous hemorrhage. Then if you can rule out a cause and get a diagnosis better, otherwise you see if the cataract is not much, you can observe or give a proper head end elevation. Okay. If you can defer the cataract surgery till the vitreous hemorrhage results, it's best. Okay. So if the VDI is not allowing you to see the retina, it's a good idea to do cataract, then see the treatment of vitreous hemorrhage. You can see here there is a subhyaloid hemorrhage or boat-shaped hemorrhage here. Okay, so these are the various causes of vitreous hemorrhage, right from diabetic retinopathy, a retinal tear, CNVM through breakthrough bleeding. Then it can be a symptomatic PVD, or Turson syndrome, or a Regmat's retinal detachment, neovascularization elsewhere, and a trauma. Coming to the vitritis, when there is inflammation, cataract, so it's always first control the inflammation. So first find out the cause of inflammation, then you plan for cataract surgery. Okay, so should be under steroid cover at least 1 week prior to the cataract surgery, especially oral steroids, and at least 3 months of quiescence is recommended prior to the cataract surgery. So this is a case of a retinitis where you can see a hazy media with a white patch, and there is a you can see a peripheral vasculitis with a perivascular exudation, and you can see inferior snow banking suggestive of an intermediate uveitis. Coming to the retinal vessels architecture, as I told you, then there is any inflammation is the venules or the arterioles, sheathing around the vessel suggestive of an healed vasculitis, exudation, then neovascularization. So you try to treat if possible, then you take up for cataract surgery. So this is showing a kind of an exudation in diabetes, or it can be an infratemporal vein occlusion with a sclerosis, or it can be a macular telangiectasia where you can see a dull FR with a macular edema, and this is showing a neovascularization of the disc where beautiful new vessels over the disc. Okay, and coming to the periphery, it's always important to treat any peripheral retinal lesions, especially lattice with hole or an HST, because then after surgery, then it can develop a retinal detachment. So it's always good idea to treat lattice with hole or prophylactic barrage if the media allows. Otherwise, you can treat immediately after the cataract surgery. Then PRP, it's noted that the patient can be taken up for cataract surgery after 2 weeks after photocoagulation. Okay, so this is showing an FFA with a leak of neovascularization in the supratemporal quadrant, suggestive of a proliferative diabetic retinopathy. So this is what all holes, breaks must be treated before taking up for cataract surgery. The chances of developing a retinal detachment should be explained, and frequent follow-up regular follow-up is required. So you can see a plain lattice Then it's a lattice with post barrage. Then there is an horseshoe tear with a subretinal fluid. So you can see there is an retinal upper cleft hole with an upper clump. You can say lattice with hole. Okay. So then this is a case of retinal dialysis. This is very important. Retinal attachment with cataract surgery. So first we have to see because if the retinal attachment we have to operate. If the cataract is minimal, go out with retinal surgery. Or if the cataract is dense, then you can combine or you can do a two-stage procedure. Then there are some disadvantages with the combined surgery where suppose you are going to inject a gas or oil, then sometimes if the PC is defective, then gas can push up the IOL or decentration of the IOL. So you can, based on your confidence and comfort, you can decide. So then this is a case of a tractional RD, a regmatinous RD and an exudative RD. Okay, so it's very important, myopia. So then you can have tessellated background, peripapillary atrophy, tilted disc, postoptic spots, the Aquercox, CNVM. So all these conditions, there will be guarded visual prognosis, especially if there is an macular involvement. So this is the case. You can see there is a pigmentation here, postoptic spots and lacquer cracks. You can see breaks in the Brooks membrane. So it's very important. What do we do for a mature cataract? We cannot see the fundus. B scan plays an important role. Before that, just see the vision, PL positivity, PR accuracy. PR accuracy is very important. Okay, the 2-point discrimination and the gross color perception. Okay, so this is a B scan showing anechoic vitreous with there is a early cataract showing a thickened posterior capsule. You can see a high amplitude spike, and a mature cataract where you can see increased amplitudes in the inside the lens. This is a case of trauma with a repaired corneal tear with a ruptured anterior capsule, and there is also, you can see in the B scan there is a breach in the posterior capsule with rupture. So it's important. First is the visual acuity, IOP. If hypotony, always suspect an RD prior to the cataract surgery. Then RAPD is a very important tool, especially in a mature cataract. So RAPD gives a lot of information. Thank you.
Wonderful talk, Ravi. The thing is, we have to dilate all these patients prior to the cataract surgery because when a patient comes with a significant cataract, we think there is a cataract and directly going for surgery. Without dilatation is not at all correct. We have to evaluate the patient and see properly retina if possible. We can predict and tell the patient this is the expected results, then there won't be any surprises and problems. So I think evaluation of retina is very, very important prior to the cataract surgery.
So when you evaluate the retina, are there any conditions where you would tell your cataract colleague not to use a multifocal or an idiom?
Usually, I tell my colleagues like cataract surgeons to avoid multifocals, especially if I have treated any diabetic retinopathy with the PRP, or if there's any like choroiditis or uveitis. So I usually avoid multifocal IOLs in such cases.
Because you would find difficulty in treating those patients further, or
I don't find difficulty, and post-op they can be glare, halos, and already the peripheral vision contrast is reduced, so it can further affect the quality of the vision to the patient.
So specifically when the IOL is using part of the light for near and distant vision, so that is the reason, not because it comes in the way.
Usually I don't. It won't affect my treatment.
Thanks.
Thank you.
Any other question from the audience?
Yes, sir.
So we will have a lot of mature and hypermature cataracts.
Correct.
And when the retina is not visible, isn't it mandatory to go for at least B scan?
Definitely, it is mandatory. If at all, if you have facilities in and around you.
Yeah.
So if suppose you are in a community or periphery where getting a cataract surgery is difficult, then expecting a B scan is.
Yeah, I recently landed in a soup because of this gap in my management. So that somehow sorted out anyhow.
I think if you can able to get the B scan, that's fine. If you don't have that facility, I think you have to tell the patient.
Explain to the
there's
patient.
significant cataract. We don't know how is your retinal status and optic nerve status. Anyway, we will be seeing the PL perception of light and people reaction and all that we will be seeing. And we know the history that patient has told that last 6 months there's a gradual reduction in the vision. Then these things will tell us something like maybe the patient is having only cataract. But we have to tell the patient that we have not seen the retina and optic nerve. Based on your retinal status only, you will get back your vision.
Don't promise 6/6 vision to this patient.
Yeah, we should
Always
not
tell,
promise.
I will do my best. So rest is recollectic glaucomas.
Whether it's hypermetric cataract, you cannot see from this. I mean, how much are vision are you going to promise the patient?
Sir, promise. The first is my idea of doing a phagolytic is first to relieve their symptoms. First is the patient is coming up with pain, congestion, redness. First is first put on steroids, control the inflammation, reduce the IOP. Then vision should be the last thing to be done. First tell, let me control your symptoms, relieve of your pain and whatever the inflammation. Then vision is the last thing to do. Exactly. Symptoms has brought them to the hospital. So they are least bothered about vision. First is like, no kadme adre saku.
First they will
So
tell
that means you are not counseled properly.
No.
That is the human tendency, sir.
No, patient will tell if the pain goes, that's enough. Once the pain goes,
Yes,
then
then they'll definitely ask.
They will be all right now, like that. They'll think everything will be 100% all right.
I think B-scan also will tell us, especially if there are advanced cupping, B-scan will pick up the cupping in the optic nerve. So if it is,
the sonologist should be good in that.
yeah, that is what.
I think we have to tell a guarded prognosis to
Definitely,
the patient.
definitely.
Request Dr. Ganesh to come.
We had a lucky dip contest at Mediville Life Sciences. Now I request Dr. Virupaksha physician to lift the slip along with Dr. Sanjay, President TYS. Three. Dr. Rao R. Megan Hospital. What is this? Mintoy Hospital, Bangalore. Sorry. Dr. Ravi. Sorry, Dr. Ravi. Sorry. Lucky. No. Next. ಇದೇನೋ ರುದ್ರ ಅಲ್ಲಪ್ಪ ಇದು ಓದಪ್ಪ ನೀನು ಕನ್ನಡ ಹಾಕೊಂಡಿದ್ದೆ ಹ್ಯಾಂಡ್ ರೈಟಿಂಗ್ ಇಸ್ ಸೋ ಡಿಫಿಕಲ್ಟ್ ವಿ ಕ್ಯಾನ್ ರೀಡ್ ವಾಸಿಟಿ ಬಟ್ ನಾಟ್ ದಿಸ್ ಒನ್ ರುದ್ರಾರಾಧ್ಯ SSMC ರಿಸರ್ಚ್ ಸ್ಕಾಲರ್ ಏಯ್ ನಿನ್ ಫೋನ್ ನಂಬರ್ ಅಲ್ಲಪ್ಪ Dr. Praveen TM, we call him as Dr. Praveen Brevis because we have two Praveen. One is longest and he is Brevis. Congrats to our winners. ನೆಕ್ಸ್ಟ್ ಇನ್ನೂ ಒಂದಿದೆಯಾ ಕೊಡಿ ನೀವಾ ಪ್ಲೀಸ್ ನೀವು ಮಿಕ್ಸ್ ಮಾಡ್ರಿ ಅವ್ರಿಗೆ ಕೊಟ್ಟಿಲ್ಲ ಥ್ಯಾಂಕ್ ಯು ಫ್ರೆಂಡ್ಸ್ ಥ್ಯಾಂಕ್ ಯು ಮೆಡಿವೆಲ್
Please do support our company. We were the sponsors of this occasion. Thank you very much. Have a good day.
Thank you very much. Dr.
Thank
Ganesh
you.
to continue.
Ganesh Satyamurthy will tell about management of posterior uveitis.
Thank you. And I think before we start, there was Dr. Rudresh Virupaksh, Dr. Virupaksh, the physician. I think I'll need his help as well to continue with it.
I think Dr. Virupaksh.
So, coming towards the end of the session, actually, this is a topic which is not so interesting as after lunch and after listening to so much of talks. Posterior uveitis, as you know, is inflammation of the choroid, mainly the choroid. It's the back portion of the uvea. Depending upon the area of the choroid, area of the uvea which is affected, the standardized uveitis nomenclature group has classified it as anterior, intermediate, posterior, and panuveitis. So we are concerned with the posterior uveitis now. So that depending upon the site of inflammation may be primarily affecting the retina or the choroid, and so the different names, either retinitis or choroiditis or chorioretinitis, which may be focal, multifocal, or diffuse. And based on again whether the onset is it may be sudden or insidious, and the duration, whether it is within 3 month duration or more, as limited or persistent, and then the course of it. Mainly it is important to know the etiology of it to manage it, whether it is infective or non-infective. Infective, there are many causes, of which the main things are toxoplasmosis, toxocariasis, tuberculosis, syphilis, and viral etiology. The non-infective ones, basically these are all appear as, like we could call it as the white dot syndrome, with multiple white dots in the depending upon the choroiditis or retinitis, along with some vitritis sometimes. And they are given different names based on their appearance. The clinical characteristics of the lesion usually will be like, depending on the structure affected, it could be a choroiditis or retinochoroiditis or retinitis or neuroretinitis or a granuloma or a mass lesion. And the symptoms, mainly they would complain of floaters, reduced visual acuity, light sensitivity, blurred vision or difficulty in seeing in the dark and seeing color. Investigations in these cases are important, as it is very important to differentiate between infective or non-infective. The further management of the condition depends on that. So we have ancillary investigations like color fundus or FFA, which is useful for documentation and for knowing the progression of the condition. FFA is especially useful for knowing the activity of the choroiditis or retinitis, denoted by early hypofluorescence and late hyperfluorescence. It can be used to detect disease sequelae such as neovascularization or as cystoid macular edema. ICG is useful especially in deep lesions, in deep choroidal lesions. And OCT, it's a non-invasive technique. It can be useful for monitoring the macular pathologies like cystoid macular edema, epiretinal membrane, or SCNV membrane. And ultrasound B-scan, it is a very useful tool, like we were discussing previously, in cases where we cannot see the retina, where cataract is there or severe vitritis or vitreous hemorrhage is obstructing the view. It will be helpful to detect an underlying detachment and to differentiate between regmaturous and exudative retinal detachment. Increased choroidal thickening, as is seen in many conditions, including posterior scleritis, where the presence of T sign or Tenon space widening is pathognomic. It also helps to differentiate intraocular tumors which may masquerade as uveitis. laboratory investigations, it has to be tailored to the based on the clinical findings where we have a suspicion, and based on that we conduct more laboratory tests to determine whether it's infective or non-infective. In cases of diagnostic dilemma, intraocular fluid evaluation for PCR reactions and antibody titers will help clinch the diagnosis. So in infective posterior uveitis, clinical diagnosis based on characteristic context picture and relevant positive history is the main thing. Lab investigations are tailored based on what we find, and specific antigen and PCR testing for the particular genome. So basic management approach is to identify the characteristic picture, confirm with specific investigation, treat the primary cause with appropriate anti-infective agents. We look at some examples later on, and then we use systemic steroids as an additional anti-inflammatory therapy, usually after starting the anti-infective agent, and then periocular intravitreal steroid once the condition has come under control and once the infection has been treated to some extent with anti-infective agent. And then in diagnostic dilemmas, intraocular fluid evaluation for antibodies or PCR for identification of the genome. Then treatment in infective conditions, primarily as I mentioned, is anti-specific anti-infective agents and then followed by systemic steroids. In case of non-infective uveitis, it is to identify the entity, rule out the infective cause, and then systemic steroids are the mainstay of therapy. If it is involving the vision threatening, like involving the macula or the optic nerve head, then intravenous methylprednisolone as a pulse dose followed by maintenance therapy. Or you can use other immunosuppressive agents as well in recalcitrant cases. And it is important to monitor the side effects. So repeated kidney function test and other blood tests would be required for that. So this is the using the systemic steroids for treating the non-infective conditions. And then there are the newer ones which are biological response modifiers like adalimumab and infliximab, and then there is ocular gene therapy as well. I think rather than go with the details of this, we'll go to some specific conditions. This is why spotter, anybody in that crowd can actually identify the lesion. Yeah. Ocular toxoplasmosis is one of the most common infective causes. A positive history of contact will be there with pets such as dogs or cats, and it is unilateral in most of the cases. You have focal necrotizing lesion like we see in the picture. So recurrent lesions can usually develop at the borders of the same. This one, it is one of the acquired toxoplasmosis. Again, the headlight in the fog appearance is very characteristic of this. So serum anti-toxoplasma antibody titers can also be used for confirming the diagnosis. In cases of doubt, a combination of PCR testing of both the aqueous or vitreous and as well as the serum testing will be helpful. So the standard treatment is with pyrimethamine and sulfadiazine. If in case patient is allergic to sulfa drugs, then you can use clindamycin or azithromycin as alternatives. This one, any cases? Toxocariosis, yes. Again, it's an accidental ingestion of larvae of dog roundworm or cat roundworm. And usually the most characteristic one is the presence of a posterior pole or peripheral granuloma, which is what we saw in the picture here with the fractional retinal detachment. Diagnosis is mainly clinical. Although ELISA with the Toxocara excretory secretory antigen has been shown to be highly specific, treatment may not be possible in most of the cases. This picture here, it is progressive outer retinal necrosis, and we have acute retinal necrosis. Both of them are manifestations of the same viral infection. Necrotizing retinitis with confluent areas in the outer retinal, with outer retinal whitening, with minimal vitritis involving the posterior pole. Giving a cracked mud appearance is diagnostic of this condition. And similarly, acute retinal necrosis, depending upon the immunology, whether the patient is immunocompetent or not, you have either PON or acute retinal necrosis. Long-term systemic antiviral drugs such as acyclovir or valsiclovir is the treatment of choice in these therapeutic retinitis. So in infected condition, we usually treat them with the antiviral or the specific agent, and then so in case of there are sequelae of these, then we treat them with steroids. Then the next condition, it is CMV retinitis. Typically, you can see that brush fire pattern there. Intravenous ganciclovir is the one which is usually used for management of this. Intravitreal injections can also be given, especially in cases where macula is threatened. Alternatively, oral valve ganciclovir can be used as this doesn't require parenteral administration. In case of neuroretinitis, with involvement of the optic nerve and the macular fan appearance, it most commonly caused by toxoplasma, TB, or syphilis, and cat scratch disease due to Bartonella is also an important cause of this. This can be treated with doxycycline in cases of Bartonella infection. This is abscess from tubercular posterior uveitis, and it can affect any site in the eye, and both hypersensitivity reaction as well as direct infection with the agent can also cause the problem. The most common presentation is tubercular uveitis, which is a form of disseminated choroiditis. The next common one is a single tubercle. Usually requires systemic antitubercular treatment. Now we come to the non-infective conditions. Usually they present with these kind of discrete or blurry white patches, multiple of them. And this is a case of APM PPE. Similarly, we have this serpiginous choroiditis, or which tends to affect the posterior pole. And then there are, depending upon the lesion, you have different types of white dot syndrome, subtle lesions or prominent lesions. Based on that, we have different various conditions. Treatment of all these are the same. It is once you roll out the non-infective etiology, then you treat them with steroids depending upon whether they involve the macular area or they threaten the vision with optic nerve involvement, and give them pulse dose of methylprednisolone or systemic or oral therapy. In conclusion, posterior uveitic entities have very characteristic clinical features and diagnosis mainly clinical. It is essential to differentiate infective or non-infective conditions, as their management is usually with or without steroids with anti-infective agents. Infective posterior uveitis needs to be managed with specific anti-infective therapy and steroids. Judicial use of ancillary tests like FFA, ICG, UCG, USG, OCT, and electrophysiological tests can complement the clinical examination. Intraocular fluid testing for PCR and antibodies in infective condition is useful in diagnostic dilemmas. Thank you.
Good presentation. You covered entirely. All these posterior uveitis patients will have some systemic pathology, and these are all representation of the systemic etiology. So, when do you send all these patients for investigations? The moment you see first time, you send for investigation?
Yeah, it depends on their presentation. Sometimes these the toxoplasmosis conditions, they are just it is picked up on a routine examination. They have come for something else and it gets picked up. For those, definitely we don't need to send them for any investigation. So it depends on the need as to their symptoms and other things. If it is picked up on for a fundus examination, which they have come for a routine for diabetes or some other purpose, then there is no need to send them for such investigations, because they are, most of the time they come up with they are not positive for any of these.
Some of these even toxoplasmosis, they will have a immunocompromised state. I think pending investigation for all posterior uveitis definitely is the option. So I think here we need the physician's guidance to help us. Actually, we sometimes diagnose as a focal retinitis, or retinitis or something. When we try to investigate and when we go for a just repair the road, that we don't sudden there it will be an ocular, we don't get anything positive here to say patient. And to start the ATTA, we have to physician and physician then would agree with us. Yes, we need to discuss that. A combination of tell about the clinical condition and the diagnosis, and then probably the physician can help us. That's okay.
Majority time we'll get a reference from the ophthalmologist that UIT, sir. So whether it's infective or non-infective, first we'll consider infective only, especially tuberculosis. Then followed by toxoplasmosis, other things will work on. Among the non-infective, we mostly suspect connective tissue disease, sir, and ankylosing spondylitis. Usually these are the commonly you can see, especially HLA, B27. Usually positive. Majority time they come with a low backache, UITs. Then if you do the HLA B27, it comes as a positive. Many cases will get a like this UITs with systemic disease, especially non-infectious diseases.
HLA positive patients, we give steroids instead of steroids to start immunosuppressive treatment. They do well. So once they start, you can taper the steroid, and if the macula is not involved, and many times you can give a very low dose steroid.
Yeah, there are with a lot of viral infections, including chikungunya and other things. There have been reports of post-viral neuroretinitis. They're usually self-limited. In case the vision is non-responding, then again either periocular steroids may also be sometimes be useful for them. But generally, not necessary to treat them. They tend to clear off. It may be unilateral or bilateral, and again depends on the vision that which they present with. We may have to consider after ruling out other causes. Generally, they come with a history of viral fever about a month back or so, and then they present with deficits in vision. And on the picture, typically we see the neuroretinitis picture on there in the fundus. Then we go about depending based on how much of the vision is affected and other parameters being negative. We think it has a sequel and we can treat with steroids.
Yes, in this area, I have seen many patients with neuroretinitis kind of picture. The first chikungunya fever. I think whenever there is a macula and optic nerve involved, we have to start a steroid. The steroid they will do very well. Thank you. Call Dr. Rakesh.
Post-COVID, there was a brief period where we used to see a bit of these kind of posterior segment issues. Any specific, is it carrying on or is it just vanished?
There was vasculopathies actually. We had brain occlusions, arterial occlusions in SIMSRH. Not in terms of uveitis kind of picture. More to do with vascular.
50 such cases post-COVID, especially those who are treated in the ICU. We had seen many cases. Myself and Dr. Swami evaluated many cases. Especially one young patient has improved from 660 to 69 vision. So it was a beautiful somehow God has saved him, if you feel. We treated with only the topical steroids and systemic steroids after evaluation of all the biochemical markers and with the OCT monitoring. So yeah, they have improved. So most of the patients improved. Only one patient had vitreous hemorrhage. It's cleared after 6 months, and another patient we had, she had 660 vision. Then the patient was seen by physician. They have advised anti-tubercular RNTCP treatment, but the patient recovered her vision only to 624. All the retinal lesions cleared, but the vision remained at 624. One entity we have seen.
Inflammatory vascular occlusions, we have seen many with post-COVID. Another thing is actually what we see is the patient also says that post-COVID vaccine I got this, all that. We are seeing vascular occlusions since long time. So all this,
The lesions were multiple. So most of the times it was bilateral, symmetrical, multiple lesions, not only at the center of the macular aptitis, it was around the peripheral retina also. And the macular thickness, it was almost about 400, 500. When we treated with topical and systemic steroids, the edema used to come down to 280, less than 300. And the retinal lesions, we call it as soft exudates, those cleared after 1 month. Let us see. Rakesh.
Great good evening to one and all. First of all, I'd like to thank my friends, Dr. Selling Swami, Dr. Dinesh, and the whole members of the Tumkur Ophthalmic Society for giving me this opportunity. And it's been a pleasure meeting all of you here. So, they've given me the topic as diabetic retinopathy, when to intervene. So, first, I'd just like to take a quick survey. The sample is quite small. So, first of all, how many of you are using anti-VEGF as the first line of treatment for treating diabetic macular edema? Can you please raise your hand? Anti-VEGF as the first line. So, how many of you are using Eylea as the first drug of choice? So, how many of you are using ranibizumab as the first drug of choice? Okay. Yeah. And triamcinolone? Requested question. Thank you, sir. Thank you. So, we all know the primary intervention starts with the patient when he walks in. We not only just look at the eye, we look at the patient as a whole. So, we need to take a whole systemic condition of the patient into view, because the entire treatment of diabetic retinopathy is mainly dependent on his the glycemic status and other comorbid factors such as hypertension and dyslipidemia, obesity, and other lifestyle risk factors such as smoking, sedentary lifestyle, and so on. So, needless to say that good physician involvement is also important for a good management of diabetic retinopathy. So, straight away jump into the management. So, it begins with a good clinical examination. So, we start off with visual acuity, and then a slit lamp examination, and a slit lamp biomicroscopic examination, and a dilated fundus evaluation. So, these are all in a clinical setting. And then we in a mass rapid screening, we tend to rely on non-mydriatic evaluation techniques with the fundus camera. And so, once we come to a diagnosis, so basically, as you all know, we tend to classify according to the ETDRS, diabetic retinopathy severity classification. So, it is a non-proliferative diabetic retinopathy and a proliferative diabetic retinopathy. In PDR, it is mild, moderate, and severe, and in PDR, it is a low risk and high risk. And also the entity of diabetic macular edema, in which ETDRS classified it as CSME. So, here are a few pictures, mild and PDR, showing a few microaneurysms and exudates in the macula. And this is severe NPDR with IRMA, where there is a pointer showing. And also the other signs like venous looping may probably be seen here. And to the left is a PDR showing a NVE, which is already fibrosing, but there is no additional traction. But the adjacent picture is showing extensive fibrovascular proliferation with a preretinal hemorrhage and probable element of traction. So it's already lasered. You can see the laser cuts in the periphery. So how do you define CSME? So clinically significant macular edema is any area of retinal thickening at or within 500 microns of the center of the macula, and hard exudates at or within 500 microns of the center of the macula, and the last one is the zone of retinal thickening, 1 disc area in size, any part of which is coming close to 1 disc diameter of the center of the macula. So with this in mind, we have been treating before the era of anti-VEGF with the laser. So the ETDRS has given guidelines as to the way of treating with the laser photocoagulation. So this is the was the mainstay of treatment until the 2003, 2004. So after which the anti-VEGFs have taken over. So the way of treating with laser involves in the stages of mild and moderate, usually observation, and in the stage of severe and PDR, we either do a scatter laser photocoagulation or a pan-retinal photocoagulation, depending on the areas of ischemia. So nowadays, using FFA has become almost obsolete, and most of it we do it visual examination. A color fundus photo or indirect ophthalmoscopic observation, and we rely on the OCT findings for treating diabetic macular edema. So treating macular edema with the ETDRS guidelines, in the first OCT picture you see a focal area of retinal edema. So usually you can see that in the center of the exudate there will be a cluster of microaneurysms which you target. So it should be well away from the center of the fovea. So treating something close to the FAZ can cause a loss of vision. And the second OCT is almost the foveal contour is maintained, and we avoid treating these kind of cases. So we usually observe. And the last one shows a diffuse diabetic macular edema. So this falls into the third criteria. So this kind of cases used to be treated with a focal, combined focal or a grid laser. So here is an illustration. The first picture shows the focal laser spots, and the second one shows the grid laser pattern. So starting from 2003 or 2004 onwards, when anti-VEGF made its entry into India, so the treatment most of us are relying heavily on anti-VEGF for treating diabetic macular edema. So the whole definition of CSME has been replaced by the OCT guided, OCT based diabetic macular edema classification. So mainly nowadays most of the treatment protocols are being advocated by the DRCR clinical research DRCR network, which is mainly multicentric trial centers based in the US and Canada, and they have been doing a wonderful work since 2000. And basically diabetic macular edema has been classified as either center involved or not involved. So the first landmark trial proposed by DRCR network in treating diabetic macular edema was a protocol I. So the results were published first in 2010, and the extended results were published in 2015. So basically, in this trial, the um, FDA approved a drug for treating as an anti-VEGF was ranibizumab. So it was compared with other standard treatments such as laser, focal or grid laser, and ranibizumab was given with macular laser. It was combined with prompt laser after the injection or deferred laser treatment. Then the other set of patients received a tricot and with the prompt laser, and the fourth set of patients received a laser with a sham injection. So in this study, it was conclusively proved that the anti-VEGF group had a superior vision, and the report of gaining vision was first reported with the use of anti-VEGF. In the laser era, there were usually not a significant gain of vision, or the vision was maintained. So then the other important aspect of this treatment is that the endpoint of treatment. So usually the treatment protocol extended for like monthly monthly intervals for continuously for a 1 year period, and after that, based on the stability of the retina and based on the OCT, the thickness map, and also the gain in visual acuity, and how the steadiness which the vision and thickness were maintained was used as an endpoint criteria, and after that the treatment was extended on a PRN basis. So just a clinical example, is a 52-year-old lady with a baseline visual diabetic and hypertensive since 8 years, with a baseline visual acuity of 6/24, and she had a moderate to severe NPDR and CSME. So this lady underwent first IVA, and she had a prompt response as shown in the first picture. But we tried following the monthly treatment regimen. But by the end of 4th dose, we can see that the edema is still persisting. So in our setting, it's a real challenge to convince the patient to continue the treatment, and hence from this point on, we tend to waver. So this is a real challenge in the real world scenario when compared to the protocol based treatments. This is another example of the same patient. In the other eye, she had actually a cataract surgery prior to the macular edema, and post cataract surgery, she started developing clinical macular edema, and again this was resistant to treatment, and she was one of the few patients who promptly underwent monthly treatments, and after the 4th dose, even she was finding it difficult to afford the treatment. So the next protocol was the protocol T, where the anti-VEGF agents were compared among themselves. The 3 drugs were bevacizumab, ranibizumab, and aflibercept. So in this study, it was conclusively proved that the Eylea or aflibercept has the major advantage, and you can see that there are 2 subsets of patients, one with the baseline visual acuity which is around 6/12, and the other set of patients whose vision was worse than that. So here it shows that the Eylea is highly effective in the patient with worse vision. So the other protocol was protocol V, where patients with who had a macular edema and maintaining good vision. So again here it was after the study, it was concluded that observation is equally good than going for a primary intervention, treating with anti-VEGF. So this is one example of a patient who presented at 1 year intervals, On the left side is the right eye. Initially he didn't have any. I had a normal foveal contour. Then he had a focal retinal edema. In the left eye again, he had a small edema, but then after 1 year it has progressed, and he was in the left eye. So again here this and you can see a systemic history that he has underwent a major surgery, and that is one of the macrovascular complications he had. That is because he was also a smoker. So these set of patients present a challenge because anti-VEGF have a known cardiovascular risk factor. So jumping into treatment for these set of patients should be we should have the second thoughts before jumping into using anti-VEGF. If possible, we can treat the left eye with a focal laser. So this is another protocol where the use of additional steroid therapy for treatment-resistant diabetic macular edema was considered, where anti-VEGF, despite using anti-VEGF on a monthly basis, there was it was refractory to treatment, and they combined it with the long-term, long-acting steroids such as Ozurdex. So here's one example. This patient, 69-year-old lady, she was diabetic and hypertensive for 5 years, and she had a greater nuclear cataract in the right eye, and left eye was pseudophakic. So on this picture of the left eye, you can see initially in the pre-op there's a convex foveal contour with a spongy edema, and after one dose of bevacizumab, she had a slight reduction, but it was not fully resolved. And from that point on, she couldn't afford the cost for the second injection. So we gave a tricot, but it shows that tricot as it was given actually post-subcutaneous, not even intravitreal, even though it was pseudophakic. So and it shows a good recovery. But in the long term, we see that this area is showing a epiretinal membrane. There's not much of traction. So this annual protocol comparing ranibizumab with the PRP, and again the protocol says that you can use ranibizumab as a first line of therapy, but we have to be cautious since the neovascularization always tend to recur, and they can also end up with traction. So there is no end to managing the patients with PDR. We have to be always on the watch out. So and this, I'll conclude with this patient's history. This 53-year-old male with diabetic for 21 years is a known case of PDR post PRP and pseudophakic in both eyes. So initial presentation, he had a fresh vitreous hemorrhage in the right eye, and left eye was stable. So he was initially advised conservative management. But after 2 months, he was for a year he was lost for follow-up because it was a COVID time. And then when he presented again in the March 23, it has progressed to TRD in the right eye, and left eye he had a non-resolving VH. So and finally the patient consents for vitrectomy, and there was no intertamponade used. I'm sorry, the pictures are missing. I think this patient actually he did well with the vitrectomy, and but he had we never used an anti-VEGF agent in this patient, and he had almost 3 episodes of recurrent vitreous hemorrhage post vitrectomy. So once we had done at the first sitting we had done a vitreous lavage. So now I am considering an anti-VEGF agent to hopefully overcome the recurrent vitreous hemorrhage. So in conclusion, we can say that screening for diabetic retinopathy early is very important, so that we have a track of the patient, and periodic follow-up will give us a picture into the progression of the disease, and we can intervene early. And proper counseling is necessary because most of the diabetic patients they tend to, because of their non-improvement of vision, they tend to change the consultants, and they end up with, taking the proper treatment. And we also had to consider their affordability because it's very difficult to follow the protocols established by the DRCR net, and so we had to promptly treat the patient with any of the established forms of treatment, whether it is laser or tricot, if they cannot afford anti-VEGF treatment. Thank you.
Thank you, sir. It was excellent presentation. So, for physician point of view, there are two important key factors that for development of diabetic retinopathy. One is the duration of diabetes. So, majority of the patient those who have type 1 diabetes, after 20 years, definitely all the patients will have a diabetic retinopathy. Likewise, more than 50% of patients of type 2 DM will definitely have a diabetic retinopathy after 20 years. Other factor will be the glycemic control, very important. That is usually monitored by glycosylated hemoglobin. So periodically you have to monitor glycosylated hemoglobin so that ensure that sugar is under control. So that is the one very important. So target level of blood sugar level in a patient with any diabetes, those already diabetic retinopathy, once developed diabetic retinopathy, there is no point in controlling sugar because that is not reverse. You can prevent the further progression of disease. So target level will be the FPS will be less between 80 to 130, whereas postprandial will be less than 180. So ensure that glycosylated hemoglobin will be less than 7. That is very important. So majority time patients will have a just sugar level will be normal, but HbA1c will be 10, 11. So that suggests that patient definitely only that day sugar level will be controlled, rest of the days not controlled, like that. So every 10% of reduction in HbA1c, there is a almost 50% reduction in the retinopathy. And also likewise in type 1. Type 2 will be almost every percentage of reduction in HbA1c, there is a 36% of reduction in the retinopathy in the future. So my question is, how often you have to do the ophthalmic examination, especially if you send physician?
It's very clearly established protocols. Anybody presenting with a mild NPDR, and we usually ask them to follow up once a year, and beyond that, moderate NPDR once in 6 months. If he has severe NPDR, then we have to watch every 3 months. And as we go on treating, it depends. I mean, if we initiated an anti-VEGF, we almost follow up every month also, sir.
In case of proliferative diabetic retinopathy, as you told, once it reaches to proliferate, there won't be any difference whether controlled diabetes or not controlled diabetes. But like controlling diabetes does make a difference on macular edema. Whenever there is a macular edema, bilateral macular edema is most of the systemic condition will definitely help us. And presence of hard exudates in the macular area, mainly leakage from the vessel. So hard exudates, many times it reduces once you control your systemic lipid level. So also the follow-up is generally if the macular edema, if we are treating and there is a vision loss with the macular edema, then every month we have to follow and based on the treatment we have to continue until the macular edema. Otherwise, if you treat proliferative diabetic retinopathy, once it is treated and well stable proliferative diabetic retinopathy, the 3 to 4 monthly regime is followed. These patients can develop sometime macular edema, and again they can develop a new neovascularization. And of course, controlling diabetes even then. So, from all the patients who are diabetic patients, the moment it is diagnosed with diabetes, retinopathy has to be evaluated because many patients. Diagnosis of diabetes itself is like already many years of diabetes. Already they will have some diabetes. many times we see with the proliferation of diabetic retinopathy, they never got to blood sugar when checked will be very high.
I think in the early part, I think what you should also realize is that diabetic retinopathy does reverse even in the non-proliferative stage. Say, for example, if somebody is not initiated on treatment vis-a-vis somebody who's put on treatment, there is down regulation of the diabetic retinopathy that we have been observing patients in a clinical trial by on semaglutide and its analogs, and we found that if you do a good control, the patients in the severe category, when we have observed them for more than 2 years, have been downgraded to moderate levels. It does happen, and it does happen even faster when when you're treating patients with moderate NPDR with DME. When you give an injection and you can see them that the amount of hemorrhages have gone away, there can be disappearance of microaneurysms. So it's not that once DR is set in, it does not matter about the control. It is extremely important that the DR should be kept on control. That's one part. Second part is, along with control of diabetic retinopathy, starting of endothelial protective agents. Something like a statin, despite the patient does not have hypercholesterolemia, does help, because although it works on the lipid pathway, but it also helps in healing of the endothelium faster. So if you see a patient who is under your care and the retinologist says that there is diabetic retinopathy, if you add a statin along with it, it does help in the long run. There also can be down regulation of DME occurrence in these kind of patients. Additional statins should be. No, even in absence of hypercholesterolemia on the serum levels, you can still start because it can help in, it is an endothelial protective. Second part is once there is proliferation. Now, here is the confusion where between the diabetologist and physician, there might be a little, the diabetologist feels, okay, why control now? Because it's already at end stage disease. What you should realize is, once we do the surgery, we clear the blood. Many a times we can also remove the neovascular tissue. Now, the part of the retina which is still there, once the neovascular tissue is removed, we have cleared off the hyaloid, correct? But if they do not control, the rest of the neurons are dying. That will increase the ischemia again. So at every given stage, it is important that diabetes is kept under control. Otherwise, what will happen is they will develop a renal damage. Along with that, they will develop secondary hypertension, and the disease now follows a feedback loop and worsens further.
Why we see there is a down reduction in the diabetic retinopathy? Because what we are seeing in the retina is we are seeing the hemorrhages, we are seeing cotton spots. So these hemorrhages and cotton spots will disappear. Generally, they tend to decrease, and the capillary non-perfusion areas will not decrease; they will remain same. So whenever there is a capillary non-perfusion area that we can't see in a regular fundus photograph or whatever we see in examination. So that will remain, because that whatever the area of non-ischemia has happened, that will keep going on. That will slow down once you control your diabetes.
During his talk, he said FA is not being done anymore. I mean, that is left to our own convenience. I think FA is a very important part of it, because there has been not a single patient who has more than moderate level of DR. With DME, if they come, I do a fluorescein even now. That, like Dr. Rao said, if you have extensive capillary non-perfusion areas, helps you to counsel the patient that you might progress to PDR faster. That's one part of it. Second part of it is macular ischemia. Although OCT can tell you, OCTA can tell you definitely, but doing the FA will help you in identifying the ischemic zones. Why we don't do it is because we would not do anything. I mean, we always link an investigation to something we intervene in the patient. I think more than that, it should be for what is called as an accurate diagnosis. That probably helps you. And even when you are doing focal laser or diffuse macular laser, doing that without doing an FA, I don't think will accurately allow you to burn the areas that are removed.
Thank you.
Dakshan.
evening, everyone. I thank Tumkur Ophthalmic Society for giving me this opportunity, and I also acknowledge Dr. Srinivas in my presentation. The topic allotted to me is management of DME with cataract surgery. So we all know that the number of diabetics are increasing year by year, and by 2040, the numbers are going to be very high, reaching up to around 642 million, and of which around 35% are going to be having some form of diabetic retinopathy, and around 11% of them are going to have a vision-threatening diabetic retinopathy. So diabetic retinopathy is a frequent complication of diabetes and is the fifth most common cause of legal blindness. According to many studies, the incidence of diabetic retinopathy in diabetic patients is around 18%, and the incidence of DME is 11%. Diabetes also increases the cataract formation by 3 to 4 fold, and we know that diabetics are going to end up in early with cataracts at an earlier age. And overall, around 20 to 30% of cataract surgeries are being performed in diabetics every year. So the risk factors for cataract formation and progression include the age of the patient, duration, the other comorbidities such as dyslipidemia, hypertension, CKD, smoking, and also ocular treatment like PRP treatment for PDR and diabetic vitrectomy. So what are the causes for progression of diabetic retinopathy after cataract surgery? It could be the surgery itself. It could be the natural progression of the disease, the diabetic retinopathy per se. It could be due to the inflammatory pathways which get activated after cataract surgery, or due to some unknown mechanisms which are yet to be understood. So after phaco, there is no evidence for progression of diabetic retinopathy if the patient has no diabetic retinopathy at the time of cataract surgery, or if there is no other systemic comorbidity, and if the patient has a well-controlled retinal disease. However, there is clear evidence for progression of DR if the patient has moderate to severe NPDR in the presence of, or if the patient has macular edema at the time of surgery, or in the presence of poor glycemic control and not the surgery itself. So this is a study which showed the percentage of diabetic retinopathy progression after cataract surgery. Here we can clearly see that the highest percentage was in patients with moderate NPDR and severe NPDR. So this is another study which had a longer follow-up of around 6 years, and they concluded that patients with diabetes may benefit from more frequent diabetic retinopathy screenings after cataract surgery. So the indications for cataract surgery, we all know if the patient has visual difficulty in carrying out their daily activities, or if the patient has, or if the visualization is becoming difficult for us for evaluation and treatment. Concerns when a patient undergoes diabetic cataract surgery include the endothelial cell loss, poor pupillary dilatation, increased risk of end-off, and for the importance for today is suboptimal vision due to post-operative macular edema. So the causes of post-op macular edema, suboptimal vision after cataract surgery include pseudophakic macular edema, new onset DME. It could be a worsening of pre-existing DME, or it could be an evolution of a non-center involving DME into a center involving DME. This is a study which showed the incidence of DME in patients who underwent who were undergoing cataract surgery. So the percentage was around 20.9% of them had non-center involving DME, and around 6.6% of them had center involving DME. So what's the incidence of new onset DME? This is a study which it was a large database study which studied around 81,984 eyes who underwent cataract surgery with 3 months follow-up. Of them, 4,485 were diabetics with no maculopathy, and of them 62.6% had no DR after surgery, and 37.4% had diabetic retinopathy after cataract surgery. And the relative risk for new onset DME is 1.8, which is high. And in the presence of a pre-existing diabetic retinopathy, the relative risk was even more higher, which was around 6.23. So what's the message from this study? The risk of developing a post-op DME is directly proportional to the severity of diabetic retinopathy. So what are the facts on DME worsening? The main risk factor is the preoperative macular edema itself. The presence of center sparing macular edema or a history of previous treatment for center involving DME, it increased the risk of developing or increasing DME up to 4 months after surgery. Concurrent DME at the time of cataract surgery is usually associated with a significant worse vision at 1 year. So another clinical picture which we usually come across after cataract surgery is this kind of a picture where it could be confusing for us. Is it a pseudophakic CME or a new onset diabetic macular edema? So then we can go ahead with the FFA and look for leaking microaneurysms, which shows us that it is mostly due to diabetic retinopathy, or if it is a leaking petaloid pattern with a disc leakage, then it is more suggestive of a pseudophakic macular edema. So if the patient has a coexisting significant cataract and a DME, both the options could be challenging. Managing the cataract first, it poses with challenges such as cataract surgery itself may worsen the DME, and if the patient needs repeated injections after surgery, it causes a dissatisfaction among patients. And if we are managing the DME first, the vision improvement after intravitreal may not be significant, and the fundus assessment also is a little difficult for doing any lasers, and it becomes a little challenging. So what are the options available for us when we are treating such patients include all these, like topical NSAIDs, steroids. Preoperatively, we can also, if the view is good, we can go ahead with the focal laser. We can also give intravitreal anti-VEGF and intravitreal steroids. This is the list again in a broader way. So if a patient presents to us with visual difficulty, and if he has a cataract with diabetic retinopathy, we have to assess the systemic status of the patient, get all the labs done, assess the diabetic retinopathy, background DR, get a preoperative OCT done, OCTA if available, FFA if relevant. So if visually significant cataract is there and there is diabetic retinopathy but the patient has no DME, you can safely go ahead with cataract surgery. Perioperatively consider topical NSAIDs and steroids to prevent post-op CME. If the patient has a visually significant cataract with DME, combine cataract with intravitreal injections. If the view is good, can do also focal laser to the microaneurysms. If the patient has early cataract and a significant DME, first stabilize the DME, get a fluid-free OCT for around 2 to 3 months, and then plan cataract surgery. Intravitreal injections and focal laser may also be considered. So first, the pharmacotherapeutic agents which are available include the topical NSAIDs. So a couple of studies have shown that diabetic patients without any history of DME, the preoperative use of NSAID for 1 week reduces the risk of new onset DME during the early postoperative period. In addition, of topical steroid did not have any significant effect in lowering the chance of post-op DME, but should be prescribed to suppress the other forms of inflammation. So prevention of post-op CME, the topical NSAIDs, how do they act? They achieve a good therapeutic levels in the vitreous chamber. They lower the risk of post-cataract CME, and this approach will definitely be cost-effective rather than the other intravitreal options. So what is new? Interferon alpha 2B has been yet in studies, and people are using interferon. Studies are going on with interferon alpha 2B for refractory diabetic macular edemas, even in cataracts, even post cataract surgery. If a patient has visually significant cataract with vision threatening DME, we have two options: either go for an anti-VEGF or go for steroid implants. Steroids, we have triamcinolone or dexamethasone implant. So this is a study which studied in which they gave anti-VEGF prior to cataract surgery, and they saw what was the response. They concluded that in real world setting, the patient with cataract and actively treated DME may undergo cataract surgery, but may see worsening of DME, not immediately affecting the vision, not immediately affecting the best corrected visual acuity. So this shows that going with doing cataract surgeries with a good, well-managed diabetic macular edema has more satisfying results. Another option available is dexamethasone implant, Ozudex. The spectrum of action is broader. It helps in managing the post-op inflammation and also stabilizes the blood retinal barrier. The duration is longer, so it acts for 3 months. The advantages over other intravitreal steroids is that it has a slow intraocular it has slow intraocular release and low effect on IOP. This is a study in which they gave dexamethasone implant 1 month prior to cataract surgery. They saw that it prevents DME worsening after cataract surgery, no visual decrease after surgery, and the benefits last usually up to 3 months post-op. This is another study in which the cataract was combined with the dex implant in one set of patients, uh, and the dex implant was given 1 month after cataract surgery. In this study, the long-term results showed that there was not much of a difference in visual outcome if the DME was managed either concurrently with Ozurdex implant or with 1 month after cataract surgery. So coming to the case scenarios, this is a patient who had moderate NPDR at the time of cataract surgery with a BCVA of 6/12. After cataract surgery, his vision improved 3 months post-op. His vision is 6/6, no development of DME. Another patient with cataract DME with asteroid hyalosis. He had a recent history of stroke, so we could not give anti-VEGF. We directly went ahead with injecting him with Ozurdex. He responded pretty well, and his vision improved to 6/9 after cataract surgery, and he's still maintaining a good vision of 6/6. Another patient with cataract with DME, 6/18 vision, we gave her intravitreal ranibizumab. The vision improved to 6/12, but however, she has been having recurrent DME, and we have been managing her with recurrent anti-VEGFs and steroids in between. So what's the take-home message is that if the patient has no DME pre-op, patient undergoes cataract surgery, no DME post-op, there is no need there is no role of any anti-VEGF or steroids. The patient only needs a frequent follow-up. If the patient has non-center involving macular edema, patient undergoes cataract surgery, may convert into a center involving macular edema. So NSAIDs would help. Of course, we have to take the help of when the patient gets into the category of center involving macular edema, we need to give anti-VEGFs or steroids as the case would be. If it's a naive center involving macular edema case, and if the patient has cataract and needs cataract surgery, and we know the patient may likely progress, consider pre-op injections, could be either anti-VEGF or steroids, plus or minus NSAIDs. If the patient has a previously treated center involving macular edema and planned for cataract surgery, we know the patient is highly likely to progress with DME, so consider anti-VEGFs and NSAIDs or steroids.
Presentation. Here I have a few doubts actually. One is the uses of NSAID prior to the surgery. Of course, it will theoretically will have an increased anti-inflammatory effect there, but I don't think it will help so much to stop the increase in the macular edema. What we have to see is first we have to check any macular edema is there prior to the surgery. In a rare situations where there is a proliferative diabetic retinopathy, extensive neovascularization, where you are doing you can't do a PRP treatment, and where there is no macular edema, in such situations, better to give one anti-VEGF injection along with the cataract surgery. So that will help us to reduce possibility of neovascularization and uveitis. So later on, neovascular glaucoma. Other than that, in macular edema, if there is a hard exudates close to the fovea, yes, high reflective material, if you see in a OCT scan or if you see a hard material near to the fovea, where it can reach and it can involve the center. So if you treat an anti-VEGF injection, it will take time to reduce or resolve that actually. So we need to give steroid if the patient is not glaucoma patient. Yes. So whenever there is a hard material close to the center, diffuse macular edema, better to treat the steroid. With the macular edema, you don't see much macular edema. Ophthalmic condition, nephropathy already. I think calling that with steroids will help a lot. Whenever
Many times the cataract is so dense that you may not be able to get a OCT. So in such situation, based on the appearance of the other eye, we may have to give a prophylactic anti-VEGF injection along with the cataract surgery, or give it before and then do the cataract surgery. Because if you have no way of assessing it, then it's likely, based on the condition of the other eye, it has some diabetic macular edema in the other eye. And for its further treatment as well, you need to have the cataract removed. At the same time, you don't want to worsen the macular edema if it is pre-existing there. So in such cases, better to err on the side of caution, give anti-VEGF and then go for cataract surgery.
I think you said in one of your cases that you did not give anti-VEGF because patient had a cardiovascular disease.
Yes, sir.
So when you go back, just read the Dex implant subgroup analysis of patients who were being treated for DME with Dex implant. Was there any cardiovascular risk factor that were seen in patients? So why I bring up this point is that even in the FAME study, where they used fluocinolone acetonide for treatment of DME, even those patients who took the implant of fluocinolone acetonide, there were cardiovascular risks. In the patients who took dexamethasone implant, they also have cardiovascular risks. Patients who took anti-VEGF injections also had cardiovascular risks. Now, what you should remember is that it's not the injection that is causing the problem. It is presence of diabetes and related vascular problem that caused the vascular event. When they did the study, they did not have any pre-existing guidelines set. So the FDA was provided a primary protocol that what will you call an adverse event and when will you call an adverse event. So in that definition, what happened was whenever they did the study, once you give that protocol is followed for every single injection. That's how the FDA functions. Now, with reference to this, many a times, many people always, keep telling that, oh, I don't give an anti-VEGF because the patient has a cerebrovascular or cardiovascular. But the point is, what you should remember is every single trial that told that if you give an anti-VEGF injection, you should be careful in these patients. It's for two important reasons. What is the most common cause of stroke? Age. At 40 years, you don't have very high incidence of stroke. By the time you take a sample of 70-year-old patient, they might have stroke because age itself is a high risk factor for cerebrovascular. Similarly, along with age of the patient is hypertensive or diabetic. In a CNVM, if you see that study, they say, okay, with injection, there were these events. If you look at the events, they were like 0.03. But if you look at the general consensus of what happens with those patients, do they develop cerebrovascular? Answer is yes. Second thing that you should remember is, when you give an intravitreal injection, we should stick to one particular argument site. So do we believe that intravitreal injection is a depot, that it will work for 30 days? Do you or do you not? Do you? You will stand on this one? Okay. Now you tell me, you gave 0.3 milligram of ranibizumab or 1.25 milligram of bevacizumab in the eye, and you strongly believe that that is going to stay for 1 month. Now you tell me, the drug which is supposed to stay in the eye for 1 month, how did it cause the cerebrovascular? When 4 gram of IV bevacizumab was given for cancer, it was first used in cancer to reduce vascularity. I hope you are aware of it. None of those studies said that the patient died of any cerebrovascular or cardiovascular. See, as ophthalmologists have a very narrow way of looking at things. We take whatever is published as baseline truth and we take that as it is there, so we will just continue. It's a repeated lie that has been told conference after conference after conference by speaker after speaker after speaker because he wanted to sound the question. But you analyze it scientifically, it is not the real truth at all.
So just a point here, sir. So if you have a patient with...
I don't shy away from giving an anti-VEGF. Whether the patient has cerebrovascular even yesterday also.
Okay.
Yeah.
It is not yet to the wrong impression. It is not a contradiction. I might be called out for this. But the point is, you answered the second question. Why didn't anybody use 4 gram IV during chronic cancer? Is that fair? 100% actually. Why? This nobody has answered in the past 10 years. So what I suggest is that everything has to be analyzed in the same scientific manner. That you stay scientific for one part of it, you will suddenly just parrot out whatever has been told for past 20 years as the same. So please don't shy away. But the thing is, you have to discuss with the patient that if you have a cardiovascular event, say for example, if a patient has TIA, his risk of developing a cerebrovascular event within the next 3 months is very high. Similarly, if I develop a stroke, the chance of me developing another episode of stroke is also very high. That has not to be related to the injection part. Now, why did they link this? I will tell you. If you measure the blood pressure of patients who are coming for injection on the day of injection, say for example, if you tell them, tomorrow I am going to poke your eye, right? They took a date and went, no, they are anxious 6 more days. You can check their blood pressure, the BP will be high. Now, what is the risk factor for CVA and cerebrovascular accident? What is it? Stress. That episode of stress is what puts them there. So this is the conversation you have to have with your patient. Very, very important. Everybody forgets that, okay, fine, the patient is having ocular problem, but we don't talk to them regarding that momentary stress that pushed it to the and we blame it on it. That means very
You don't even take a clearance or anything like that. Straight away you
I
go
have never
ahead.
taken a clearance for a fluorescein angiogram because I know the dye is inoculation. I know the dye is unmetabolized. I know the dye is excreted. But in the book it is suggested that if you have chronic renal failure, you are supposed to. What does the nephrologist know about the dye? You are using the dye. He never heard of it. He will treat it as iopaque. Iopaque is a radio opaque dye that they use for cardiology. That dye is known to cause ionic dissociation and sudden failures. He will probably think that even fluorescein is like that. Fluorescein undergoes only one step in the body, which is glucuronidation. If I put fluorescein in your body, and if I collect fluorescein from your body after about say 6 hours, I will not get sodium fluorescein. I will get sodium fluorescein glucuronate, which is highly soluble but can be excreted. It is absolutely not metabolized. Now, the nephrologist will say, okay, it's contraindicated because so and so creatinine, you don't do it, and you don't do it. I mean, thank God that the dependency on fluorescein has gone down now. But otherwise, depending on them is not the right way to do it. You should know the compound that you are using, and then use it. Otherwise, don't use it. Don't use it in the part that a cardiologist has given a clearance. He doesn't know. He has written, yes, cleared, but on what basis? That is the most important part. But as doctors, I think we should know more about it and then use it rather than just pick up lines saying that, okay, I will avoid because it is this. It is the fear of the unknown that is not making you.
Another thing is when Lucentis came actually, so the cost was very high. The study, once it is done, actually what it showed is that the number of people after a few years of taking Lucentis and Avastin, comparatively Avastin group had a more number of repeat strokes or cardiovascular issues. That means actually the people who are taking Avastin were poor people. Their systemic control were also lesser. So because of the body conditions, maybe there are few people got more, not that the drug change. So everybody started saying that you give only Lucentis, don't give Avastin. I have given, because of the patient conditions, we have to give some injections, either one. That time only either one is available. So I have given many patients with Avastin only, telling all this to them actually. I have not seen a single patient having another stroke or another cardiovascular.
It's not just a matter of experience, it's also microscience. Avastin is a large body. Ideally speaking, on other complicated anything from the eye is far less. But despite that, this guy goes there. Nobody questions it. Because the company did not want to operate on a license. They were doing it as an operating. They did not want to. At the end of the day, the buck starts. You are the physician, you are taking the patient, you are responsible. You should not somebody else giving you go read the Tumkur. It's very, very interesting.
Yeah, when we keep telling in these podiums that there is a risk of cardiovascular problem, avoid these patients. So I don't think that's really that much important. Thank you.
Thank you.
So thank you very much. So at the end, we are going to facilitate our speakers from our TOS members. Dr. Manjunath S. to facilitate Dr. Tirumalesh, Dr. Ravi B. Sir, Ravi sir. Dr. J. Siddhananda Swami to Dr. Rakesh. Dr. Vipaksha sir. Dr. Jayadevanda to Dr. Gachani.
ಏನ್ ನೋಡ್ತಾ ಇದೀಯಾ? ಜಾಗ ಕೊಡು.
ಸೈಡ್ ಸೈಡ್ ಲೇಡೀಸ್ಗೆ ಜಾಗ ಕೊಡಿ.
ಇಲ್ಲಿ ಫುಲ್ಲು ತುಂಬಾ ವಾಸನೆ.
ಮುಂದೆ ಬನ್ನಿ.
Dr. Suresh sir. Thank you very much for your wonderful participation. We gave a feedback form to many people. Many have written it's good, it is fantastic, wonderful. But our good friend Dr. Ramamurthy has written in a different way. I call upon Dr. Ramamurthy sir to present his feedback. So Dr. Ramamurthy sir is a senior consultant and is working at KC General Hospital as a DMD teacher, alumni of MMC.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ನಾನು ದಿನೇಶ್ ಮತ್ತೆ ಗಣೇಶ್ ಅವರೆಲ್ಲ MMC ಅಲುಮ್ನಿ ಬ್ಯಾಚ್ ಅಲ್ಲಿ ಇದ್ದೀವಿ. ನಾವು ಸ್ವಲ್ಪ ದಿನೇಶ್ ಜೊತೆ ಅಸೋಸಿಯೇಷನ್ ಜಾಸ್ತಿ ಆಗಿದೆ, ಯಾಕಂದ್ರೆ ಈಗ KCG ನಲ್ಲಿ ನಾನು ಸೇರಿದ್ಮೇಲೆ ಅಲ್ಲಿ DNB ಟೀಚಿಂಗ್ ಎಲ್ಲ ಶುರು ಆಗಿದೆ. ಹಾಗಾಗಿ ತುಮಕೂರು ಅವ್ರ ಜೊತೆ ನಮ್ದು ಇಂಟ್ರಾಕ್ಷನ್ ಬಹಳ ಮಂಜುನಾಥ್ ಜೊತೆ ಮತ್ತೆ ದಿನೇಶ್ ಜೊತೆ ಮತ್ತೆ ತುಮಕೂರು ನಲ್ಲಿರುವಂತ ಟೀಚಿಂಗ್ ಫ್ಯಾಕಲ್ಟಿ ಜೊತೆ ಬಹಳ ರೆಗ್ಯುಲರ್ ಆಗಿ ನಡೀತಾ ಇದೆ. ಈಗ ಏನಪ್ಪಾ ಅಂತಂದ್ರೆ ನಮಗೆ ಅವ್ರದ್ದು ಐಡಿಯಾಸ್ ಬೇಕಾಗುತ್ತೆ, ನಮ್ಮ ಐಡಿಯಾಸ್ ಅವ್ರ ಜೊತೆ ಡಿಸ್ಕಸ್ ಮಾಡ್ಕೊಳ್ತಾ ಇರ್ತೀವಿ. ಅವ್ರ ಸ್ಟೂಡೆಂಟ್ಸ್ ನಮ್ಮ ಹತ್ರ ಬರ್ತಿರ್ತಾರೆ, ನಮ್ಮ ಸ್ಟೂಡೆಂಟ್ಸ್ ಅವ್ರ ಹತ್ರನು ಎಕ್ಸಾಮ್ಸ್ಗೆ ಇದಕ್ಕೆಲ್ಲ ನಡೀತಾ ಇದೆ. ಹಾಗಾಗಿ ದಿನೇಶ್ ಯಾವಲ್ ಒಂದೇನಪ್ಪಾ ಅಂತಂದ್ರೆ ಯಾವಾಗ್ಲಾದ್ರೂ ಒಂದ್ಸರಿ ನಮ್ಮ ತುಮಕೂರಿಗೆ ಬನ್ನಿ, ಒಂದ್ CME ಬನ್ನಿ, ಸ್ವಲ್ಪ ಕನ್ನಡದಲ್ಲಿ ಮಾತಾಡಿ, ನಮ್ಮ ಹುಡುಗರಿಗೆಲ್ಲ ಸ್ವಲ್ಪ ಕನ್ನಡದ ಬಗ್ಗೆ ಒಂದ್ ಸ್ವಲ್ಪ ಒಂದು ಆಸೆ ಮೂಡುವ ಹಾಗೆ ಏನಾದ್ರು ಮಾಡಿ. ಅದರಿಂದ ಈಗ ಕನ್ನಡ ಪುಸ್ತಕಗಳೆಲ್ಲ ಕೊಟ್ಟಿರೋದು ನೋಡಿದ್ರೆ ಗೊತ್ತಾಗ್ತಾ ಇದೆ, ದಿನೇಶ್ ಕೊಟ್ಟಿದ್ದು ಎಲ್ರಿಗೂ ಕನ್ನಡ ಪುಸ್ತಕ ಕೊಟ್ಟಿದ್ದಾರೆ. ಹಾಗಾಗಿ ಏನಾದ್ರು ಒಂದು ಸಣ್ಣದಾಗ ಒಂದು ಕವನನಾರು ಬರೀರಿ, ಒಂದು CME ಬನ್ನಿ ಅಂತೆಲ್ಲ ಇತ್ತು. ಸೊ ಅದಕ್ಕೋಸ್ಕರ ಫೀಡ್ಬ್ಯಾಕ್ ಫಾರ್ಮ್ ಬಂತು. ನಿನ್ನೆ ದಿನೇಶ್ ನಂಗೆ ಬಿಡಲ್ಲ ಅಂತ ಗೊತ್ತಿತ್ತು, ಹಾಗೆ ಸ್ವಲ್ಪ ಒಂದು ಐಡಿಯಾ ಸ್ವಲ್ಪ ಫ್ರೇಮ್ ಮಾಡ್ಕೊಳ್ತಾ ಇದ್ದೆ. ಅಂತೂ ಐಡಿಯಾಸ್ ಮಧ್ಯಾಹ್ನ ಊಟ ಆದ್ಕೊಳ್ಳೋ ಸ್ವಲ್ಪ ಕಂಪ್ಲೀಟ್ ಆಯ್ತು. ನಮ್ ಶಿರೀಶ್ ಹೇಳಿದಾಗೆ ಮುದ್ದೆ ತಿಂದ್ಮೇಲೆ ಸ್ವಲ್ಪ ನಿದ್ದೆ ಟೈಮಲ್ಲಿ ಐಡಿಯಾ ಸ್ವಲ್ಪ ಫ್ಲೋ ಆಗ್ಲಿಕ್ಕೆ ಶುರು ಆಯ್ತು. ಸೊ ಫೀಡ್ಬ್ಯಾಕ್ ಬಗ್ಗೆ ಬರ್ದಿದ್ದೀನಿ, ಅದು ಆದಷ್ಟು ಸರಿಯಾಗಿ ಓದ್ಲಿಕ್ಕೆ ಪ್ರಯತ್ನ ಮಾಡ್ತೀನಿ. ನೇತ್ರಕಲ್ಪ TOS ನ ಹೆಮ್ಮೆಯ ಕನಸು ಅದ್ಭುತ ನೇತ್ರಕಲ್ಪ. ಸೇರಿಯವೆಲ್ಲ ಸಂತಸದಿ ಮಾಡಿ ಮನಸಂಕಲ್ಪ, ವೈಜ್ಞಾನಿಕ ಮೇಳದಲ್ಲಿ ಮಿಂದು ಚಿಂತೆಯ ತೊರೆದಿಹವು ಅಲ್ಪ ಸ್ವಲ್ಪ. ಕಲ್ಪತರು ನಾಡಿನಲ್ಲಿ ಸಂಭ್ರಮದಿ ಸಮಯ ಕಳೆದು ಪಡೆದಿಹೆವು ಕಾಯಕಲ್ಪ. ಸಡಗರದ ಬಗೆ ಬಗೆಯ ಭರ್ಜರಿ ರೊಟ್ಟಿ ಮುದ್ದೆ ಹೋಳಿಗೆಯ ಊಟೋಪಚಾರ, ವಿನಿಮಯಗೊಂಡಿಹವು ಹಲವು ನೇತ್ರಶಾಸ್ತ್ರ ವಿಚಾರ. ವೈವಿಧ್ಯ ನವ ವಿಷಯಗಳ ಸಂಕಲನ 10 ತರ, ಕಾರ್ಯಕ್ರಮ ರೂಪುಗೊಂಡಿಹುದು ಸಂಪೂರ್ಣವಾಗಿ ಮಹತ್ತರ. ಸಹೋದ್ಯೋಗಿ ಸ್ನೇಹಿತರೊಡನೆ ಬೆರೆತು ಕಲಿಯಲೊಂದು ಸದಾವಕಾಶ, ಯುವ ನೇತ್ರ ವೈದ್ಯರು ಜೊತೆಗೂಡಿ ಬೆಳೆದು ತರುವರು ಅಂದರಲ್ಲಿ ಪ್ರಕಾಶ. ಈ ಸದೃಶ ಕಾರ್ಯಕ್ರಮ ಮೂಡಿ ಬರಲಿ ಪ್ರತಿ ವರುಷ, ಮತ್ತೆ ಮೊಗದೊಮ್ಮೆ ಸೇರಲು ನಮಗೆಲ್ಲ ಬಲು ಹರುಷ. TOS ಉದ್ದೇಶಿತ ಬೆಳಕಿನೆಡೆಗೆ ಸಾಗುವ ನೇತ್ರಕಲ್ಪ, ರಾರಾಜಿಸಲಿ ಸೂರ್ಯ ಚಂದ್ರರಂತೆ ಪ್ರತಿ ನಿಮಿಷ. ವಂದನೆಗಳು. ಥ್ಯಾಂಕ್ ಯು.
ನಮ್ಮ ಹಿರಿಯ ಮಿತ್ರರಾದ ಡಾಕ್ಟರ್ ರಾಮಮೂರ್ತಿ ಅವ್ರನ್ನ ಹಾಗೆ ಕಳಿಸ್ಲಿಕ್ಕಾಗತ್ತಾ? ಸೊ ಅವರಿಗೊಂದು ವಿಶೇಷ ಅಭಿನಂದನೆಗಳನ್ನ ನಮ್ಮ TOS ಪರವಾಗಿ ಸಲ್ಲಿಸುತ್ತಿದ್ದೇವೆ. ಕರುಣಾಳು ಬಾ ಬೆಳಕೆ ಅಂತ ಹೇಳಿ ನಾವು ಒಂದು ಅಡಿವಾಕ್ಯ ಹೇಳಿದ್ವಿ. ಆ ಕರುಣಾಳು ಬೆಳಕಾಗಿ ಇವರು ರಾಮಮೂರ್ತಿ ಅವ್ರ ಮೂಲಕ ಬಂದಿದೆ ಅಂತ ಅನ್ಕೊಂತೀವಿ. ಥ್ಯಾಂಕ್ ಯು ಸರ್, ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್.
ये हमें कवर करता है, पर इनको कौन कवर करता है? टाटा AIG हेल्थ इंश्योरेंस का कॉम्प्रिहेंसिव कवरेज.
Good evening, all. As we know, once we get up in the morning, dawn will come and we will go to sleep. Same way, time has come to end Nethrakalpa 2024. How we have passed the time and what's the result, that will be all known by you. And we have accomplished what we want, and hope with what intentions you have come here, you have accomplished. For this accomplishment, as speakers, guest faculty from different parts of Karnataka have come here and they have given the feast of knowledge with respect to all subspecialties of ophthalmology, and which we have taken that. And we are greatly thankful to all the guest faculty who has come here, along with our local co-moderators who has cherished still the subspecialties in a better way. And I am thankful to the guest, Dr. M.R. Ulinayakar, who is head of Sridevi Group of Institutions, who has inaugurated these functions and unveiled our Tumkur Ophthalmic Society website, that is tumkur.org. And our KOS President, Dr. K.P. Kudlu, he has come and unveiled our TOS logo, and they have given their intellectual words regarding what TOS should be done next. And I am very thankful to the delegates who are still being with us as a part, even after the time, with such enthusiastic. And I'm greatly thankful to you all to be here and join with us to make this a grand event accomplished. With that accomplishment, you must have to say how it is. And once we have said and thankful to this, now I'm having an immense pleasure to thank Dr. Lavanya Raman who is the main pillar of Sridevi Institute of Medical Science, where she has taken tremendous risk for this whole of 1 week to make this event a grand successful with a team. And to name a few, Karthik, who has closely associated with both TOS and Sridevi, who has done this program a success. And I will take all the teams, even from housekeeping to the top, who are directly or indirectly involved in making these functions, including IT and these decorations, front wing, back wing, which we won't be knowing, but at the end, what we want, we have got. And I am greatly thankful to Mr. Raghavendra of Sridevi Engineering College, who has designed this website in a short period of time. And I'm also thankful to Justinate, who is an advertising company, who has done this logo design. And I cannot say anything regarding Tumkur Ophthalmic Society, which we are still seeing here, how we have done it as a teamwork, where all the people are still here with the same spirit and enthusiasm. And with just a seed initiated by our senior ophthalmologist, I mean to say senior member, Vishwanath sir, and which is planned and executed by all the senior members like Dr. Sanjay, Dr. Kaleshwar, and even Dr. Dinesh and all other team. And I'm greatly thankful to scientific program which are well planned by Banushree and Manjunath. Yeah, and that too, we are very grateful that they have started exactly at 9 and they have continued still with the same spirit. And also I am thankful to the media person who have covered this whole program, and also I am very grateful to the IT team who have completely whole program has been streamlined live in a website of cost.org. And what we have already accomplished is still the same team spirit what we are here. Now today Nethrakalpa has hand, and today we are now Tumkur Ophthalmic Society, which is having a great challenges in the front, where we must try to reach further steps where we can accomplish still more better. With these words, we are concluding this Nethrakalpa 2024. Thank you one and all. Sorry, I've taken just the name of Sridevi front and back, and I am also very thankful to the PGs and the students who have taken part from morning and who are still they are working with this backstage activities. I am extremely thankful to you all people. And we will have high tea and we will disperse.